Good morning, and thank you for joining us virtually for Withum's third annual Healthcare Symposium. My name is Rachel Gisser, Senior Marketing Coordinator of Withum's Healthcare Services team. We have an exciting program planned for you today. Industry experts will share their expertise on their insight on the latest developments in the current healthcare landscape to put your organization in a position of strength in today's health economy. Topics include what we can expect for the future of healthcare, leadership and financial considerations in the industry, and cybersecurity concerns in healthcare and how to keep your organization safe. We'll be offering 3 CPE and CLE credits for this program. I will go into those details a little later on how to qualify. On the right of your screen, you will see a toolbar where the handouts for today's session are located, as well as a chat box for questions. During the program, feel free to write in your questions and we will do our best to address them. With that, it is my pleasure to introduce Bill Hageman, Withum's Managing Partner and CEO, who will kick off today's program.
Thank you, Rachel, and thank you for all you do to organize this event for us. We're very excited to be presenting our 2021 Healthcare Symposium. We have a large group of people from across the country that are joining us today, and it just shows the depth and breadth of our reach into the healthcare industry and how excited and how committed our firm is. We're the 25th largest firm in the country. We're doing about $280 million of revenue. We have about 1,500 people working for us. So as a large employer, we know very much what many of you may be going through as you try to navigate through the residual of the pandemic. And quite frankly, I would be remiss if I didn't thank you all for your heroic efforts. When we all went virtual 18 months ago, we had no idea what to expect. And I think that what the healthcare industry has accomplished has been absolutely phenomenal over the last 18 months, and gives us confidence to be able to move forward and to try to get somewheres back to business as usual. I know that we have many challenges. The Omicron variant is probably just the latest in what will be multiple variants as we look forward over the next year, maybe 2 or 3. And we will have to continue to be flexible as we deal with our people and as we deal with trying to get our economy back to where it was. We're all trying to get back to the office. I know many of you are experiencing this too, especially for your back office folks. And that is coming with tons of challenges, especially around vaccinations. Do we require it? Do we not require it? I know many of you have, some are somewhat hesitant. And then finally, there are staffing shortages. In our view, staffing shortages will continue to be a problem throughout the next decade. The basic demographics of our country are not running in our favor. As more baby boomers retire, then we have Gen Zs coming into the workforce. So there are plenty of challenges that you guys have to look forward to, and that pretty much we all do, and it's every industry that I get to speak to. And you know, the point though, the takeaway is that we're here to help. We're here to talk it through. We're here to provide you advice to the extent that we think it can be valuable, or find new resources to the extent that we don't have them within our own great firm. So with that, I want to thank you for joining us again. I hope that you enjoy our program, and we look forward to having a very dynamic group today, and I look forward to you continuing to work with our great firm, and I thank you very much for choosing us and choosing Withum and choosing to be here. So with that, back to you, Rachel, and everybody have a fantastic day today.
Great, thank you so much, Bill. Here is a quick look at our agenda for today. So from 11:15 to 12:15, we'll have Dr. Stephen Klasko of Jefferson Health and Jefferson University doing our keynote presentation. Session 1, 12:30 to 1:20 will be our CEO panel. Session 2, 1:30 to 2:20 will be our CFO panel. And session 3 from 2:30 to 3:20 will be our cybersecurity panel. And here is the CPE and New Jersey CLE credit information. To qualify for credit, you must answer each polling question throughout the program and complete the survey at the end. There will be 4 polling questions at the beginning of each panel session at 12:30, 1:30, and 2:30. Withum will handle CPE, and NJHA will be distributing CLE credits, and certificates will be emailed by early January if you meet the criteria of answering the polling questions and completing the survey. More information can be found on the following slides. And I will now turn it over to Scott Mariani.
Thank you, Rachel, and good morning, everybody. I'm Scott Mariani, partner at Withum, and I'm our firm's practice leader of the Healthcare Services Group. Again, I'd like to welcome you to our Healthcare Symposium. We're thrilled that you're joining us here today. At this time, we'd like to acknowledge and thank our collaborators for this year's event. First, the New Jersey Hospital Association, including Kathy Bennett, Sean Hopkins, Roger Sarro, and others from that great organization. Secondly, we'd like to thank the New Jersey HFMA chapter for partnering with us again this year, and also specifically the New Jersey FACT Committee, Finance, Accounting, Capital, and Taxation. A specific thank you to Jill Squires, current New Jersey HFMA president, and the FACT co-chairs, Alex Filipiak and Hannah Hartnett. And thirdly, we'd like to thank and recognize the Hospital Association of Pennsylvania, including Jolene Calla, Joe Tibbs, Lori Mulholland, and others from that fine organization as well for collaborating with us again this year. On the next slide, we'd also like to acknowledge the co-partnering of various other organizations who contributed to making this healthcare symposium a tremendous success this year. And now at this time, it is my pleasure to introduce today's keynote presenter and speaker, Dr. Stephen K. Klasko, President of Thomas Jefferson University and CEO of Jefferson Health. We will be showing a presentation that Dr. Klasko prepared for today, and then Steve will appear live for an interactive question and answer session. So please use that question chat box that Rachel had outlined earlier. We're excited to have Steve here today. Steve is an advocate for transformation in healthcare and higher education. As president and CEO of Philadelphia-based TJU and Jefferson Health since 2013, he leads one of the nation's fastest growing academic health institutions based on his vision of healthcare at any address. Jefferson Health has grown from 2 hospitals to 18 hospitals under his tenure, and also includes a Medicare payer organization and pioneering a connected care initiative. In addition, with the 2017 merger of Thomas Jefferson University with Philadelphia University, this created a professional university with top 20 programs in fashion, design, health, and the first design thinking curriculum in a medical school. Steve's track record has earned him a place tied for number 2 most influential individuals by Modern Healthcare in 2018, and is number 21 in Fast Company's 100 Most Creative People in Business 2018. Steve is an obstetrician, has been dean and CEO of 2 additional colleges of medicine, and believes that creativity is the key skill for students in the age of augmented intelligence and robotics. Please join me in welcoming Dr. Klasko. Rachel, please start the presentation.
Hi, I'm Steve Klasko, and I've had a hell of a morning. This morning I woke up in 2030. Now back in 2021, I was the president of Thomas Jefferson University and the CEO of Jefferson Health. Now, I'm the chief digital officer for the United States under President Taylor Swift. Yes, the Swifties became a real political party, and the president has just received word that there is a mutant strain of an RNA-encapsulated virus that's been afflicting people in Australia. Of course, People old enough to remember, especially healthcare workers, the dark days of 2020 and 2021 and the COVID-19 crisis immediately panicked, but only for a second, and then they smiled, because they knew that healthcare had evolved from a broken, fragmented, expensive, inequitable sick care system to a health assurance system where most of their care happens at home here in 2030. Since most of your healthcare data is now continuously streamed to the cloud, and AI bots are constantly analyzing them for any changes, the early symptoms of this new virus were immediately identified, and anyone throughout the world who exhibited those early symptoms was notified and asked to socially isolate. If needed, their employer was notified and asked for an excused absence. Software was immediately sent through the Internet of Things, what we now call the Internet of You, so your home 3D printer could begin to create masks for you and your family. Those who were having panic attacks, remembering the COVID-19 crisis of 2020 and 2021, could immediately communicate with their bot psychiatrist, and if necessary, could immediately receive drone-delivered treatment. There were no lines or concerns about food or supply storages for the same reason. Humans are not the dependent variable, as the fourth industrial revolution, drones, AI, Internet of Things, and robotics, have modified the supply chain, and there's no reason to congregate in crowded grocery stores or hoard toilet paper. The whole scare was over within a month, as new bioprocessing techniques were able to identify, develop, and test vaccines through rapid prototyping. Oh, by the way, instruction for K-12 students continued seamlessly, as the United States had finally reached broadband in 100% of households by 2025. And just as healthcare at home was mainstream, so were creative ways of teaching in a variety of venues. Okay, so now let's travel back to the present in 2021. I'm committed to working with you to make sure that that brief time travel is indeed a reality. A far cry from what we witnessed in my hometown of Philadelphia and throughout the country during the COVID crisis of 2020. While not enough can be said about the frontline healthcare heroes at Jefferson and throughout the country, data was scarce and not analyzed in a coordinated fashion. There were different strategies in different states, in some cases different counties of the same state. Jefferson Health went, as I said, from 50 telehealth visits a day to over 4,000 a day, but many health systems did not have the bandwidth to accomplish telehealth. And speaking of bandwidth, most public schools shut down for months as cities such as Philadelphia had a large percentage of the population without broadband or computers at home. The war on the underserved, which is what historians called the reaction to the 2020 COVID crisis, forced a change in payment models so that every aspect of the healthcare ecosystem was compensated for keeping populations healthy. Food deserts were eliminated through drone delivery and enlightened social and educational food programs. Payers and providers aligned, once doing better, not doing more, resulted in higher payments. It was not an easy road. The dirty, not so secret of healthcare in 2020 was that almost everybody made more money when more people were sick. It was hard to get big institutions excited about changing something when their revenue depended upon them not changing it. So the healthcare industry had failed to transform itself over many years. Consumers, business owners, and all rational people recognized how healthcare had escaped the consumer revolution as they watched hospitals fall and insurers have record profits during the COVID crisis. They watched the underserved and minority population dwindle because we had failed to address the social determinants, and they recognized that things that they took for granted were difficult in healthcare. Even telehealth, believe it or not, in 2020 was viewed as a new technology. That failure of entrepreneurs in the traditional healthcare ecosystem to get together urgently to disrupt healthcare became incredibly visible throughout the COVID epidemic of 2020 to 2022. Throughout the crisis, no one worried about groups of people congregating at banks to get their deposits checked because everything they should have happened in healthcare had already happened in banking. The data was continuous, owned by the consumer, and almost all transactions could be done at home in 2020 in banking, unlike healthcare. With health assurance, we moved from the Internet of Things to the Internet of You. I remember back at Davos in 2020, the CEO of a banking conglomerate came up to me and said, 20 years ago, the two groups that had totally escaped the consumer revolution were banking and healthcare. Now you're alone. Think about how the pandemic, even back in 2020, would have been handled differently if we had continuous data coming in from patients through their wearables and other sources as it related to temperature, respiratory rate, and other vital signs. Or if 3D printers were as ubiquitous as cell phones. Simply put, in many cases, our cars back then got better care than we do. They were constantly sending data to the cloud. It's hard to believe, but only 10 years ago in 2020, people were going once a year for a static physical to an office, as opposed to what we have become accustomed to, your t-shirt sending continuous data with AI filtering and human interaction when necessary. For example, the discrepancy between those healthcare systems that had a strategic alliance with a payer versus those that didn't came into sharp view during the COVID crisis. Healthcare providers were forced into canceling elective or non-essential surgeries and outpatient visits, the very services that brought in the dollars for the fee-for-service sick care world to subsidize the money-losing chronic care management. Meanwhile, payers that already received their premiums had huge reserves and were paying out much less because these services were not being performed in order to conserve PPE. Since the system was not set up to be nimble, COVID pneumonias, by and large, were paid for as run-of-the-mill pneumonias, despite the fact that the expenses for the provider for that care were often quintupled. Bottom line, providers were forced to put thousands of employees on furloughs or layoffs, insurers were able to decrease their medical loss ratios, and patients who lost their job often also lost their health insurance. For places like Kaiser and other integrated payer provider systems, they were to work out the economic maelstrom. Everyone else was left to react and fend for themselves and their employees. All in all, great progress is made in delivery of health, and the transformation would not have been as dramatic if not for the COVID crisis of 2020. In some respects, in a weird way, more lives were saved over the past 10 years because of the pandemic of 2020 to 2022, was a jolt and lightning rod for American healthcare to have an extreme makeover and for the sick system to finally get well. So how do we get from 2020 to 2030? Well, I want to take you back. I had an opportunity to work with Apple in the pre-iPhone era, and John Sculley, who had become the CEO of Apple to sort of get Steve Jobs to understand corporate America, had asked Steve to come up with a strategic and business plan like they had at Pepsi, which he ran. John's view of that was a very large, glossy brochure with spreadsheets, McKinsey, Accenture helping out. Steve's version was simply this. Here's my 3-year business plan. Year 1, we change. Year 2, we change the industry. Year 3, we change the world. So how do we change? Well, a book was written by one of my mentors, a guy named Bill Kissick at Wharton, who literally talked about the iron triangle of healthcare. The book was called Medicine's Dilemmas, Infinite Needs, Finite Resources. Sound familiar? And he said, there's an iron triangle of access, quality, and cost. If you increase access, you either have to increase cost or decrease quality, and you can go down the geometric line. He said, unless you're willing to disrupt the system, and disruption is painful. And literally for that whole early part of the decade of the 21st century, think about what our health policy was. The Affordable Care Act, President Obama said, this will increase access, increase quality, and decrease cost, and it won't be painful. That's impossible. President Trump said, my healthcare program will be terrific, fantastic, unbelievable, and huge, and it wasn't. But the simple fact is nobody wanted to do the disruptive things that would have really made the difference. This is healthcare's Amazon moment. If you're a provider and think you're going to go back to your business model solely being based on hospital revenue and not relevant to people who want care at home, I think you'll be out of business. If you're an insurer and you think you can just be the middleman between the hospital and the patient, you'll be irrelevant. If hospitals believe that innovation can just be this cute little thing that they do in the background, but the real business is just getting heads in beds, they're nuts. I think we were always wondering what the big disruption would be that got us to join the consumer revolution, and I really believe that this is it. So let's think about the iron triangle in a very different way, from the patient's point of view, because people don't view themselves as patients. They view themselves as people They want to be able to thrive without health getting in the way. They want to be able to connect and have human relationships with healthcare providers when they need it. They want to be able to easily navigate healthcare on their own terms like they can every other part of their life. And they also want to be able to understand what they do. And understanding is different than transparency. Transparency is CMS saying that I have to put my ChargeMaster 2,800-page Excel spreadsheet on the internet. Transparency is, I need a hip replacement. I run half marathons. I want to know, based on your outcomes, what are the chances that I can do a half marathon in a year? Exactly what will it cost me? What rate of readmissions do you have and who will pay for it? What do patients say about you? And then I want to be able to go to other providers and get that information, just like I can in every other part of my life. That was the main thing that changed. At Jefferson, we made that decision in 2017, that we were going to go to a 4-pillar model, what Steve Jobs used to call the old math and new math. The old math was making computers and operating systems, which was the only math back then. The new math was the digital lifestyle. In our world, the old math is tuition, academics, and our 14 hospital system. The new math was innovation, strategic partnerships. And right around 2020, the innovation strategic partnerships pillar actually became our most successful pillar. So the question for us when I got a chance to take over Jefferson in 2013, can a 195-year-old academic medical center act like a startup company? And we made a few assumptions. We assumed that we would get paid based on quality, cost, patient experience, and outcomes. We assumed that our hospital stays would become commoditized. We assumed that our doctors and nurses will not only have to work with, but cooperate with deep learning entities. It took us about 50 years to get doctors and nurses to work together. Now we're going to have to get doctors and robots to work together. We also recognize that if that's the case, then we need to select and educate our humans differently. And that population health, predictive analytics, and social determinants really need to move to the mainstream of clinical care, payment models, and medical education. When I started out in obstetrics, what would happen is a young woman would think that she might be pregnant. We do a pregnancy test, go to her family doctor, say, congratulations, Mrs. Jones, I'm going to send you to my obstetrician, Dr. Klasko. The chances that a 28-year-old person today will just take that advice for the most important thing in their life from a 64-year-old male primary care doctor are zero. So she'll say, well, that might be who you'd go to if you get pregnant, which you probably won't. I'm going to talk to friends. I'm going to look on the internet and decide who best matches what I need. So we decided actually to create that Match.com between patients and providers, because finding the right doctor shouldn't be so hard. Same thing with remote monitoring. We're working with a company that literally can do most of pregnancy testing at home. Now think about this post-COVID, not just immediately, for years to come. The chances that a patient that needs 3 times a week non-stress tests will say, oh, let me get this straight. You want me to come into Philadelphia, pay $35 each time to park, go to a place where there's a lot of sick people, go up in an elevator, have somebody put a monitor on me that's been put on 10 other people so I can stare at the ceiling and have a nurse come in 2 hours to tell me that the baby's normal, when I can do that at home while I'm binge watching my favorite show with a glass of lemonade. That's really the difference that once people start to see those alternatives. And I really think Jack Ma at Davos last year really put it best.
No matter how artificial intelligence is good, human being in the future compete with the machine on knowledge, you don't have a chance. Computer is always going to be smarter than you are. When there's a car, forget about who runs faster. When there's a plane, don't think you can fly like a. When there's a computer, you know, computer is always smarter than you are. They never forget. They remember everything. They never get angry. They calculate faster. But computer can never be as wise as a man. What's the difference between smart and wisdom?
So how do we change the world in healthcare? So let me tell you what scares me about the digital acceleration caused by COVID-19. It's that we'll get it wrong. We have this unprecedented opportunity to shape this 30-year industrial cycle that will transform almost every sector of the world economy. We now know that digital technology will be ubiquitous. We'll stop calling it digital, just like we don't call it telebanking. But it's our responsibility to get this right, to create the restructuring of the next 100 years that will leave the world a better place. We now know that this new technology will be infused throughout the world economy. That means the pressure is on us to make sure it's done responsibly. In some respects, that's why Heyman and I started talking about on healthcare. We're convinced that truly putting the person in the center, whether that person is a patient or not, can integrate healthcare, make it consumer friendly, but also solve the health disparities that help create 20-year life expectancy gaps between zip codes in America. But only if we design the healthcare system with those disparities and with that ethics in mind. So what happens if robots and humans actually start to work together to provide better health? I wrote an article for Modern Healthcare after my time at the World Economic Forum, and we're actually working in that stakeholder capitalism world about recognizing that the two crises that really do not have any borders are both climate change and healthcare inequities. So here's what happens once you go from sick care to health insurance. I mentioned the pregnancy model of the difference between having to come into the hospital 3 times a week to get your baby monitored versus being able to do it at work or home. So what does that have to do with disparities? Well, the simple fact is that we are somewhere around number 45 of 100 developed countries in maternal mortality and neonatal morbidity. Now think about that. Why is that? With all the resources we have, we're by far the most expensive. It's because of that gap. And just think back to the testing model. If you're a wealthy person, no problem coming into the hospital 3 times a week, paying for parking, taking the time off. If you're in a very different situation where you can't take that time off, or you can't afford childcare, or you don't have money for gas in your car, what you do is you just don't get the testing. Once we democratize that testing, though, by being able to do it at home, literally we're able to make significant changes in maternal outcomes. There is no reason that in a place like Philadelphia with 6 academic medical centers should be a 21-year disparity between going 6 miles on either side of the Rocky statue. So one of the things that came out of our Davos discussions were that we need large-scale transformations in healthcare to both survive as a business and have a positive societal outcome. And again, I believe that COVID will be a nidus for that. The 4th Industrial Revolution will give us the tools and data to do this, but we need to proactively address the human and ethical consequences up front. And healthcare and academic success, 2 areas that really need to go through disruption, will require changes in our way of thinking, creative partnerships to create new ecosystems. And by the way, there is no such thing as non-disruptive disruption. It will be painful for those who don't want to think differently as these new ecosystems are built. That's been true in every area that's been transformed. Think Sears and Penny's. Think travel agents that didn't get the importance of e-travel. Oh, and what about food deserts? Well, think about this. In 2020, the reason there were food deserts was because certain zip codes, those one with long life expectancies, might be able to walk to 2 or 3 Whole Foods or Trader Joe's. The ones with much less life expectancies could only walk to a bodega that sold corn chips and sodas. And they might not have been able to afford the gas. The combination of enlightened health policy and drone delivery of food changed all that. The enlightened health policy was that if you're willing to give your family healthy meals, we'll give you 50% more electronic food transfers if you're on food assistance. And by the way, we'll drone deliver to you. Literally eliminating food deserts. Just one of the examples where smart policy, AI, and the human component made a difference. Oh, and the final mandate for AI, we finally started to learn from our mistakes.
condoms. Fun, sexy, safe.
Just like that guy, we keep making the same mistake over and over again. So we started to look at simulation in a whole different way, transplanting medical advances and knowledge into improved patient care through procedure rehearsal studios. I'm a private pilot, and every 2 years I have to get my technical competence assessed. As a surgeon, nobody's assessed objectively my technical competence in 30 years. In fact, we talk about the way training is. If you ask any surgeon, how did you learn this procedure? See one, do one, teach one. That makes zero sense in 2020. And over the decade from 2020 to 2030, that went away. Just to give you an example, I learned how to intubate a 1.5-pound baby in the middle of a chaotic delivery room. Now, nobody does that until they've proven that they can do it on one of these simulated little 1.5-pound robot babies, knowing that they can do it safely before they get to a human. Jason Kidd got traded to the Dallas Mavericks, and the team had been 24-52. And at his press conference, this is what he said: "We're going to turn this team around 360 degrees." We do a lot of turning things around 360 degrees and ending up in the same place in healthcare. And that's what really had to change starting in 2020. And most importantly, if there's one thing that this crisis has shown us, is that we have to start now. Thank you very much. So let me give you a few surprises and really cut the suspense. You did start in 2020. You did make those changes. You did go from sick care to health assurance. And that's why things are so good in 2030. Oh, and by the way, one other surprise. I'm not really me. I'm a hologram of me coming back to let you know that you're just about to start a renaissance in healthcare. Now I'm the real me again.
Wow, Steve, that was really terrific. On behalf of Withum, Smith & Brown, we want to welcome you live to our Healthcare Symposium. Terrific presentation. Glad to have you here today.
No, thanks. It's great. It's a great time to be talking about the future of healthcare.
Absolutely. And you've recently announced this year that you're retiring from Jefferson. I want to congratulate you on just a terrific run and wish you best of success with what your future career holds. I know you've been passionate about the reduction in health disparities, for example, as well as talk frequently about the digital transformation in healthcare delivery. In your talks and in your video, you started at 2031. And yeah, me too. I'm a big Taylor Swift fan. Hello, the whole Mariani family is terrific. From you personally, what's the appeal of science fiction as you've led and continue to lead cultural change at Jefferson and around healthcare generally? Maybe we can start with that.
Well, I think science fiction and actually what I've written some of the books around and that video was history of the future have a similar thing. You can do things in science fiction that are very provocative that won't get people quite as upset. And I just always think back to, I'm a big Star Trek fan, and when Captain Kirk actually kissed Lieutenant Uhura, that was at that time a Caucasian guy kissing an African-American woman. Like, if you had just done that on a regular TV show, that would have been amazing. But what basically Gene Roddenberry said, well, it's 2140. What do you want me to do? I think that as a, I guess I've been called a disruptor. I like to think of it more as a creative constructor in healthcare. When you talk about science fiction, like the book behind me called Bless This Mess, a picture story of healthcare in America, asterisk, this is not a children's story, it's scary, was pretty critical of our current fragmented, expensive, inequitable system. But the concept was that somebody came back from the Intergalactic Council of Awesome Healthcare Systems in 2035, came back to 2020 and said, boy, I don't know how you got from here to there. So we could do some things that were a little bit more controversial because they were happening on other planets. Everybody got the fact that it was basically criticizing what was happening on this planet. But I think, you're able to get away with it, and usually it gets people to think a little differently. So I think science fiction, it's when you think about a lot of the things that we think about now, Star Wars and that kind of thing, it allowed us to think differently in a more creative way.
What I found amazing was the change in age expectancy just within a 10-minute, approximate walk from the Rocky statue in Philadelphia, which is obviously a great city. And healthcare delivery today being broken. What do you mean by that? And can you maybe elaborate a little bit about that? And then also some of your thoughts about how do we as a healthcare industry really start to address the social determinants of health and the health disparities?
Yeah, look, I think it's a great question. I'll be in January. I'll be going out to Davos because I help lead the digital economy and new partnerships. And it always hits me that we talked about developed countries and developing countries, but the healthcare discrepancies in Durban, South Africa, are not as bad as the healthcare discrepancies in Philadelphia, Pennsylvania. And some of it gets down to what we've cared about, right? I mean, if you just think about the healthcare ecosystem, there's the providers, there's pharma, there's the payers, right? So for the providers, it's always been about how can I get paid to have sick people go into my beds? Well, that's not helping folks, necessarily stay healthy. And the payers have been, frankly, how do I make sure I continue to get my 17 cents on the dollar to make sure that the people that pay for the care get the care and provide the care don't talk to each other? Well, that's not necessarily keeping people healthy. And then pharma is, how can I do, commercials on Morning Joe for $400,000 stage 4 lung cancer drugs? So now, by the way, all those things are what they should be doing on behalf of their shareholders, but none of them is necessarily getting, Mrs. Jones, an underserved patient in South Philadelphia or North Philadelphia, healthier. So, the realization of Ken Frazier when he gave us that gift was that, he literally had a 20 times increased chance of having a stroke where he grew up in 18th and Tioga in Philadelphia than where he lives now, 9.2 miles away. What was different about what Ken and Andrea did though, is they said, we want this Frazier Stroke Center to be where we grew up, which is not in Jefferson's territory. It's actually in Temple's territory, which is a competitor. So I called the president of Temple, who's a good friend, and we've gotten $5 million. I called him up. I said, Dick, I want to give you $2.5 million. And he said, look, one of the things that Mama Engler taught me is if anybody calls you up and says they want to give you $2.5 million, it's probably like a Nigerian prince, and I should hang up. And I said, well, yeah, that's usually good advice, and I went through the whole thing of how we could work together. That's a great example of where two great health systems are really getting out there. The big Novartis deal that we're doing is called Closing the Gap. It's getting out to barbershops. It's getting out to homes. So I think the issue is that nobody's really in charge of that, right? Right. I mean, nobody's in charge. The reason we want to start the Philadelphia Collaborative for Health Equity is that I made 25% of my personal incentive around, reducing health inequities, and that forced my folks to start to look at that. In my new world, which will be more in the t-shirt and jeans venture capital world, I want to make sure that the $1 trillion spent on the transformation of healthcare isn't just making the wealthy healthier, right? That we're starting to look at how do we take population health, social determinants, predictive analytics out of the philosophic and into the mainstream of clinical care and payment models.
Yeah, completely agree. And the New Jersey Hospital Association has done a lot of research in something called last year the zip code analysis, and they're real passionate about this whole issue. And I know Kathy Bennett, the president and CEO of NJHA, is on our first panel here this afternoon, and they've done great work and continue to do great work. And it's really Scott, getting into those neighborhoods.
Yeah, I gave a talk for the NJHA, and they do great work. And I think one of the things that we talked about is it is a sin that this country does not have a Universal Connectivity Act. I mean, people during COVID, think about that. If you didn't have broadband, you were in virtual jail. You couldn't do online education, you couldn't do telehealth. So what we're going to find when we do the PhD thesis on the 3 years of By the way, everything I look at in COVID is BC, DC, and KAC. Before COVID, during COVID, and kind of after COVID. So we have to get away from this bright line of, oh, there's going to be a point, we're in the kind of after COVID stage today. Like the Omicron thing is sort of a little bit of a red herring, but we're going to be KAC for a while. And KAC has to be, we should never, ever again have people in virtual jail because they didn't have broadband.
Yeah. Hey, I've got one more question myself, and then Rachel, maybe you can turn it over to you and we can get some of the questions from the audience. And this is really, really great. You recently closed on Health Partners Plans, which is a large HMO Medicaid population service primarily, and brought it into your system. Can you maybe just comment about the collaboration, bringing into the system? What do you hope to achieve as kind of bringing that in? I think that's just really neat. I think the audience would love to hear about kind of your vision for bringing that into Jefferson.
Yeah, I believe strongly that, and I don't think that every system has to own an insurer. And I think what you'll find about Jefferson, both, in my last several months here, but also, after I leave, is we'll have lots of different ways we're working with insurance companies, but there's got to be alignment, right? If you looked at what happened during COVID, the American hospitals lost hundreds and hundreds and hundreds of millions of dollars. If you own stock in United or Humana or Aetna, it was the best stock you could have. So, well, that doesn't make any sense, because what they do is they went to the employer, Scott. They went to, your employer and said, this is what I think we're going to spend in 2020. And they spent a quarter of it, because we weren't able to do elective surgery. Well, that's way too fragmented. So I think that what we're going to have, we have a accountable care organization that will some point announce a relationship with another insurer. The Health Partners Plan is great because it's Medicaid and Medicare Advantage, and this is what it means. It means for the first time, I'm involved in the first dollar of premium, so that if I keep somebody healthier and out of my hospital, I'm not getting penalized for that. Does that make sense? So when we started telehealth in 2013, spent $35 million, and I came up with a model where half of my patients could not have to come to my ER and be taken care of through telehealth, urgent care, or an appointment the next day. The problem is the insurers would pay us $1,500 if somebody came to my ED, whether they needed to or not, an average of $90 if I kept them at home. So we did it with our 35,000 employees at first, where we were the payer, the provider, and the employer. It was unbelievably successful. So I think that's where I see this happening. I think every large health system will have to have some kind of value strategic alignment with a payer.
Yeah, completely agree. And rather than being an adversarial relationship, it needs to be collaborative, and it needs to be passed along down to the consumers, i.e. myself, my family, et cetera, where it needs to be that personal experience that you talked about and not a commodity type thing. And I think the example you raised about, Mrs. Jones comes in, finds out she's pregnant, and go to this,
right,
obstetrician, and, the choice and the knowledge and the information that's out there for choice, it's really not there in healthcare, as
right,
opposed to going out and buying a car. And I don't mean to analogize those two things, but there's lots of information and readily available, and you can pick and choose. And in healthcare, you don't have that as much. And certainly, from a consumer perspective too, and an employer, and, we have about 1,500 people in our firm, and we're always looking at, how do we control these premium costs? And
right,
even in COVID, 18, 20% increases, and we're hearing that from our clients. And wait a minute, they really didn't incur things. And, the collaboration between payers and providers really, really needs to be better. And just comment on that.
Yeah, I mean, we're at odds in how we get paid. I mean, I was on a cable news show. I said the pandemic proved that Senator Sanders was 100% right about the problem, and the pandemic proved that Senator Sanders was 100% wrong about the solution. And what I meant is, it certainly proved that we were sort of this broken, fragmented system. Somebody wins, somebody loses within the system, but the patients are stuck in the middle. Okay, so you get an A for that, Bernie. I think the concept of, well, let's get the federal government, state government, city government, and local and county governments all work together, because clearly they'll work together seamlessly to run the whole thing. I think vaccine distribution sort of proved that that's probably not a good idea to have them run the whole thing. So what we're trying to do in Philadelphia with some of the things we're doing is solve the problem on our own. And one of the questions in the chat is, I don't know, do you want to bring that up? But there's a couple good questions in the chat.
Rachel, go ahead. Let's take a few from the audience, please.
Sure. Okay, so this question is, do you see the US having a national digital health passport? It can hold consumers' vaccine testing and other medical data in the cloud that consumers can store, access, and share with anyone they need to. That's the social capital goal of DigiVax, to reduce social inequities. And that was the
look, the answer is yes, yes, and yes. It's just asinine that we are so far behind in health compared to everything else, right? I mean, think about what you can do in banking. You don't get up in the morning and say, I'm going to telebank. It's just that banking went from 90% in the bank to 90% at home. So as it relates to digital health passport, I think the answer is yes, with a caveat. We have to figure out how to use blockchain like we do for cryptocurrency to make sure that your data is secure, right? I've spent the last 18 months with the former CTO for President Obama, looking at what the guidelines and guardrails are when all your health data is out there, right? So yes, I think having a digital health passport that even includes your genomic data, et cetera, is great, unless somebody can steal it, or unless Google's going to use it, for advertising. So we should have by now had a digital vaccine card. I mean, I think we should have digital, driver's licenses. I mean, it's ridiculous that I have to, if I lose my driver's license, have to go to a DMV. I mean, that doesn't happen if I lose my Amazon user ID, right? So it should be the same kind of thing. I think believe it or not, one of the things that really holds us back, and it's just ridiculous, and we're about the only country that doesn't have it, and it's probably because of all the fragmentation, is we need like sort of a digital ID number. Like we need like every other country has a single health ID number that any place you go, it's like your social security number that you can go to. And the problem we have in healthcare is one insurer doesn't want to share information with another insurer. Even like if I'm trying to track a patient and that patient gets admitted to a competitor, often the insurer doesn't want to share that data because then they know what we pay that competitor. So I think we have to decide that we're going to break up that fragmentation and use data in a really exciting way and bring blockchain and crypto type technology to make sure that it's safe, because trust is really more important than technology. And then I think, yes, we should have digital passports and have have healthcare join the Amazon revolution.
Right. Our next question, are there any specific things Jefferson has implemented to address the clinical and non-clinical staff shortage issues that are having a major impact on providers in our region?
Boy, that is the operative question. I mean, I'm sure you guys read some of the same things that I do. Everything is a turnover tsunami and the problems in workforce. So I think as with any crisis, you have to start get to the root causes. So some of it is just pure burnout. If you look at the nurses in a place like Jefferson or Penn or Temple or Cooper, a nurse that went to heal folks, might have, if they're in a low risk unit, 10 people die in a career under their watch. I mean, it was happening in some places 10 a day. Not only that, it's a little bit, we talk about going to war and the PTSD. These folks were going to war, from 7 to 7, and then going home and taking the war home with them. So during the surges, I mean, we have pictures of our nurses that couldn't play with their kids because they were afraid before the vaccine came. We're playing with their kids across screens. So, and I think the other thing that really hurt that is the Delta variant, because I think people got, okay, this is done. And then the Delta variant hit and it was all over again. That's when we start to really have people look at a lot of things. So I think what's happening, so what have we done? We've actually accelerated some of our nurse graduates. So we're bringing, if you will, to use the war analogy, some fresh troops. That's great. They're excited. They're passionate. They're getting to work earlier. The negative of that is, because some of the senior nurses are leaving, we're having nurses 1 or 2 years or even less out of nursing school that are shift leaders, and that you lose some of that experience. The other thing is just the whole labor issue that other sectors are seeing, that because of the extension of unemployment benefits and that kind of thing, that some of our lower paid employees, the $17 or whatever an hour employees, could felt that they were just as well unemployed. And frankly, and I think this will have an impact on labor costs, but because of the increase in wages in the Chick-fil-A's of the world, they can go, and if they're environmental service workers, they go and work for Chick-fil-A for the same price with a lot less angst and tension. The problem becomes, as we start to increase labor costs, we're, at least those of us who are not-for-profits are sitting at a 1% margin. And for all the reasons we said before, it's not like the insurers are going to say, "Oh yeah, I understand, your problem, Steve. We'll just pay you more." I mean, that's not going to happen. So the issue that we have is continued compression of our traditional revenues. And at Jefferson, one of the things I'm very proud of is we've watched those traditional old math revenues go down, but then we start to invest in some of the digital revolution and the $1 trillion that's being spent on digital transformation, and that will replace some of those revenues.
And how about, Steve, can you comment on private equity and venture capital in healthcare, kind of alternative revenue sources? We've seen a lot of activity in that area. And despite the regulation in healthcare, can you kind of comment on what you see going on and the continued, I'll say, partnering and or PE come into healthcare? Yeah, look, I think it's, first of all, I mean, it's unbelievable. I mean, you put A and I in the same sentence and you'll get $200 million worth of funding, Now, there's a lot of discussion in the world that I'm moving toward, whether that's a bubble or whether that's, just the sixth industrial revolution, right? I mean, if you think about the last 20 or 30 years or 40 years ago, it was search engines and social media. You could start anything. And people said that's a bubble. Well, it really wasn't, right? I mean, people said, well, yeah, after Twitter and Instagram and those kind of things, what else is there? Well, Snapchat, TikTok, bubble, and there's going to be hundreds more. I think this will be the next one, that whole that whole AI, robotics, drones, genomics revolution. So the question is, how do we participate in that? Now, part of that is because we've been lazy. When I say we, the traditional providers, payers, right? I mean, you look at an Oak Street or a One Medical, basically what they've become is $30 billion companies by just saying, we're going to be nice to patients and low risk patients, we'll see it in 15 minutes. Well, we could have done that. We just said we weren't going to do that. By the way, we could have done what Judy Faulkner did with Epic and EMRs, but we said, hey, if a nurse can't read my handwriting, get a new nurse. And we created we let these other companies create these several billion-dollar things. So at Jefferson, what we called it the old math and new math. It's a little bit like my time at Apple, as I said. The old math was computers and operating systems. That's going to be bad math. The new math is digital lifestyle. So the new math for us is investing early on in things that are going to cannibalize our traditional revenue. So a hospital at home, we will have significant founder shares in a company that will cannibalize our inpatient revenue, but in 5 years, that might be worth $100 or $200 million. Yeah. And the development of JeffCare Connect, I mean, and maybe you can comment, I know in the video you did about the telehealth visits in 4,000, maybe just for everybody here, you can go into a little more detail about that, which turned out to be absolutely brilliant and really good for the consumers in a major pandemic like COVID. Yeah, look, that was where I had my I'm mad as hell, I'm not going to take it anymore moment. I was working with Ido Schoenberg in American Well and Joe DeVivo in Teladoc, and I recognized, wait a second, this is going to be another example where Jefferson becomes a pilot
for something we could have done on our own and creates a $20 billion company, and I get a fleece and a dinner out of it. So we decided that instead of just mailing it in and saying we have telehealth so that some doc from Detroit can answer my patient's calls at 2 o'clock in the morning, we said, look, we're going to create Jeff Connect, and I invested $40 million in 2013, which you can imagine my faculty was not thrilled about. And I went to one of those companies and said, look, you can be the Intel inside for Jeff Connect, but it's going to be all our ED docs. And we even got to a point, let me give you an example. We got to a point where we created an urgent care center a block away from our hospital's emergency room. Because we basically told everybody, look, get on to Jeff Connect, and we might decide you need to be seen, but why should you go to the trauma ED and spend all that money and wait 5 hours? You'll go to our urgent care center, and if you need to go to the hospital, we'll send you there. So we created this whole, and now we have this thing, even if somebody shows up in our ER, there's a kiosk, and they actually get on Jeff Connect to decide where they should go. So I think that, that's a great example, and I'm glad you brought it up, Scott, of us seeing a trend, and instead of just frankly being lazy and buying a product, we invested. We had major investments in American Well and major investments in Teladoc, and we did it on our own so that when they became IPOs, we were making some money, and we had Jeff Connect. So, we're doing a lot of that in the whole AI world, hospital at home world, and other things where we can be part of that. I view our 18 hospitals and our in-person tuition at some point as being a loss leader, just like Apple views MacBook Pros as being a loss leader, and we'll make most of our money through these transformations.
Great. Rachel, another question from the audience?
Yep, and just a reminder, keep sending in your questions. We have Dr. Klasko until 12:15, so feel free to keep sending them in. You've said healthcare delivery today is broken. What do you mean by that?
So look, I think what I mean by that is that we're the only sector in the country that hasn't joined the consumer revolution. There was a recent Harris poll that, there were 3 or 4 things that were damning, but one of the things was that 62% of people believe that we purposely make the health system incredibly complicated so that we can charge more. Well, that's not true, but that's pretty damning, right? About 70% of the people said that they get so disgusted in how they have to interact that they often forego care. My daughter was pregnant, got it delivered during the pandemic, and she used my address as her insurance house, and I got 62 bills between the provider and the insurer, of which about 50 said this is not a bill. I'm sure you've all been through that. So then why the heck are you sending me that? And I was on the board of a company, again, that's going to become a several billion-dollar company, that literally that all it did was say, look, don't send those stupid "this is not a bills" in the mail. We'll organize it all and give the patient on her iPhone, one, this is what you owe and why. So, when I say it's broken, we've got way too much into this, hi, I'm a doctor, you're lucky to see me. I don't have to do anything like other sectors do around customer service. What I tell everybody is, and I said this on the video, I want to be Target and Walmart. Because, when Amazon, created that e-revolution, there were some people said, oh my God, nobody's ever going to the store. Sears and Penny said, this is a fad. When somebody has pancreatic cancer, they don't care what our digital strategy is. We have one of the best pancreatic cancer surgeons in the country. But, for the 97% of people in Philadelphia that don't wake up in the morning and say I'm a patient, even if they have diabetes or congestive heart failure or cancer, we want to be their partners so that when they actually have a problem, they're not going to go up and down the Schuylkill Expressway and say, who's got the coolest billboard. So I think it's broken. I think COVID proved how broken it is, that literally folks were not able to get care. We're going to find that a lot of people died, not of COVID. We thought they had COVID, but they had chest pain. They were afraid to come to the hospital. They didn't have broadband, and they said, well, I'll just deal with my chest pain, and they died in their sleep. And we might call that a COVID death. It's broken because we have all these folks that are still uninsured or underinsured and mortgaging their house to get cancer care. It's broken because in any other industry, if you were going to give more people access, then you would have sold all of your middleman stocks, like payers and supply chain stocks. So that's what happened in every other sector, and that would have been a mistake. How can healthcare become less expensive and more efficient, and have the payers, the middlemen stocks go up by 11 times? The best stock you could buy, when the Affordable Care Act got passed, were some of the payer stocks or the for-profit hospital stocks or pharma stocks. So how can healthcare become more efficient if those traditional middleman stocks are basically flourishing? So when I say it's broken, it's not broken for an individual patient. Hey, I often say, we have Star Wars technology for individual patients in a Fred Flintstone healthcare delivery system. So if you are on Jefferson's concierge service or Penn's concierge service or Cooper's concierge service, you have access to everything, best in the world. But if you look at the health of every individual in our community compared to some other countries, we're not the best in the world.
Let me change gears and ask a question here, if I may, Steve. More toward the FTC and now their stance on kind of anti-large healthcare systems and mergers. You obviously were successful in bringing in Einstein and growing it up to 18 hospitals now, and the largest, integrated healthcare delivery system in and around Philadelphia, Delaware, southern New Jersey. What would you tell the FTC if you wanted to do another deal and they said, no, you're too big, it's not good for the consumer? And maybe you can just comment on your thoughts there on why it's good for the consumers, better for healthcare, consumers, cost, convenience, et cetera.
Yeah, look, there's a lot of things I'd like to tell the FTC, but I'd like to have a career after this. I think the issue is it's right and wrong, and if you just look at Philadelphia, we're like we're the poster child for it's right and wrong. The FTC will say, and they're correct, that that a lot of these consolidations have not resulted in better care and lower cost. So that's what they've looked at. Having said that, if you look at a place, let's look at Philadelphia, right? I was the dean of Medical College of Pennsylvania that sold to Tenet, and Tenet closed that place. I was the Drexel and Hahnemann, sold to Tenet. Tenet sold to a hedge fund guy and his wife, closed that place. Actually, now I think of it, maybe it's me. I've been the dean of every place that's closed. But when Hahnemann, the place for the underserved got sold to Joel Freeman and his wife, nobody argued about that, right? Then it closed. When we have a situation now with Tower, it's getting sold to a for-profit, and when Einstein, which was the last non-state-owned safety net hospital, like 90% Medicaid, Medicare, government insurance, and the choices were going to a hedge fund person or his wife or a UPMC or whatever. We had to spend 3 years and $20 million to fight it. And a lot of the people we fought beyond the FTC were the insurers. So the whole model of, commercial insurers are going to have to pay more because Jefferson is big is a 1980s model. I don't think anybody thinks that Jefferson has a monopoly with Penn and Temple and Cooper, and So I think we have to think about motivation. And my last thing to the judge was when I was testifying was when Hahnemann closed. I said Hahnemann is the canary in the coal mine for the underserved in Philadelphia, and your only decision, Your Honor, is whether or not the people in North Philadelphia are stuck in that same coal mine. I mean, that's how I viewed it, whereas the FTC viewed it around economic circles, et cetera. So look, I think we have to have a more customized approach in a place like Philadelphia there's like 40 hospitals. If you really look at the whole greater Philadelphia area, there's only really 4 insurance companies. So, who really has the oligopoly? I mean, that's one of the questions to ask.
Correct. And there's been the consolidation on the payer side in the insurance company through the years, and they've gotten very big. And also point too, with very similar with Crozier Keystone Health System, which served a large portion of uninsured or uninsured, and so sold to a for-profit, and now it looks like they're potentially being sold again, and that's not good for healthcare and not good for those people in those communities. Certainly.
Right. Look, I'm a big fan. Yeah, I'm a huge fan of not-for-profit healthcare. It's not perfect, but the situation is I report to a board that are community leaders in Philadelphia. If we don't satisfy our community mission of we improve lives, then basically that board is going to fire me and get a new team. If you're the head of a national for-profit, not that there's anything wrong with that, but the only people you're really beholden to is your shareholders. And that shareholder in Ohio is not really going to care if you're taking care of poor babies in Philadelphia. So there's this motivation thing. We were not kidding that we decided to merge with Einstein because it was the best thing for the city. It's where our medical students went, etc. I'm not sure, and I can't speak to motivation, but I'm not sure it was as clear that Joel Friedman, bought the real estate around Hahnemann because, he necessarily cared for the underserved in Philadelphia. Maybe he did, but it didn't work out very well.
Great. And moreover, right across the river, in New Jersey, I know the legislature has now tried to pass some, and you use the word transparency with pricing, but transparency with some of the for-profit hospitals that have come into New Jersey with making certain financial information, certain transactions with companies that the owners own or their family members own that have to be disclosed and made public, kind of trying to get some transparency out there with some of the for-profit hospitals, because they're not real transparent with some of their business practices. And I have to just give a shout out to NJHA and trying to get a little fairer playing ground between the for-profits and not-for-profits. And I'm a big proponent of tax-exempt not-for-profit healthcare as well. And I remember very early in my career, I went and we visited a new hospital prospect, and it was, a struggling exempt system, and they had the big for-profit right down the road, and the CEO was still swore to us, and I'll never forget it, that, that they bought a school bus and they were bringing all the uninsured and underinsured and dropping them off at her ER, so things like that.
Yeah, well, look, I think you're right. I mean, I think New Jersey is a great example. You look at, where we're at in South Jersey, we have Cooper, we have Virtua, we have Jefferson. What we did with acquiring, and merging with the Kennedy system, was not, was the whole idea was bringing, that kind of, world-class Philadelphia nonprofit healthcare to New Jersey, not sending it to Philadelphia, which is what had traditionally happened. And, we work well with our colleagues, in some cases competitors of, Virtua and Cooper, since we don't have the cardiac surgery certificate of need, we send them to those colleagues. And then in North Jersey, we have an academic partnership with Atlantic Health. Atlantic Health is such a great example. I mean, Brian Gregnotti has done an amazing job with the ACO there and some of the work they've done in reducing costs, taking care of everybody. And, look, the one thing I'll pat ourselves on the back, when Hahnemann closed, if you remember, we had Senator Sanders rallying, people are going to be out in the street, nobody's going to take care of those people. We took care of those people. We got 70% of those, between us and Temple and Penn and others, we absorbed them. Those patients got just as good care. It was a financial huge hit. We didn't go and, oh, poor us. It wouldn't have happened in a different situation. So I think we ought to applaud a little bit of what we've been able to do in New Jersey and in Pennsylvania, and then start to look at how we start to get ready for this very different future.
Rachel, another question from the audience?
What are you doing to bring non-acute components of the delivery system into readiness for 2030, especially in the post-acute era?
So look, I think the key is, and I sort of said it in a funny way, we have to become like banking. I mean, so one of the things that we did or we're doing, actually I have a call coming up with Microsoft today, is we were looking in Philadelphia, what do we build? Do we build a new hospital? Well, I think hospitals are going to become places where really, 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 really sick people go, people with ICUs, people with infections, et cetera. Because when you think about it, if you need a knee replacement, why the heck would you want to go to a hospital where there's immunosuppressed people and people with infections and people getting transplants? That's why we have things like hospital-acquired infections. So what we're building in 11th and 12th and Chestnut is what we're calling the space station between home and what will be very different general acute care facilities. And I think more and more and more and more non-acute care things will happen starting at home. So when let's say you come to our ER and we say, well, you need IV antibiotics or you need some tests. I think about 60% of those people will go home. And we'll set them up with IV antibiotics at home. We'll see them. We'll do some of those tests at home. And by the way, you're going to have better food. Well, if you don't have better food than the hospital, then who's ever making your food, your partner needs some work. But I'm going to assume you have better food. And you probably have a nicer TV. And you're going to feel more comfortable. And so much of that stuff we could do at home. And by the way, if you need something surgical, then in most cases, you're going to be able to go to our space station, our specialty care pavilion. And then the things that will be done in the hospital will be the really, really, acute things that need that kind of acute care. So I think what we'll start to see, using that Target and Walmart analogy, is that more and more stuff will be made quicker, will be made easier to you. You want it the same day. You can either get it at the Target locker close to your house, or we'll send it to your home tomorrow. Or there are certain things you'll need to go to the store. And I think what we're wrestling with now is exactly what can we safely do at home? What can we safely do at an outpatient center? The Rothman Institute at Jefferson is a real jewel. And, when I got to Jefferson, they moved 700 cases out of our university hospital to their hospital, Rothman Orthopedic and Surgical Hospital. Well, that was probably the right thing to do. It was a low-risk hospital. Now they've moved most of those out of their specialty hospital to outpatient centers. Now, that doesn't help my traditional revenue, but it's probably the right thing to do, and we're partnering. And I think you'll see more and more non-acute things like that.
Interesting. So you recently wrote the book, Unhealthcare. Can you just comment, and you mentioned it certainly in your video, can you comment on health assurance for the audience?
Yeah, so if you look behind me, there's a book called Unscaled. Unscaled is my partner, Hemant Taneja, he was the guy that was the initial investor in Airbnb, Warby Parker, and Stripe. And he wrote Unscaled about that, right? So he said, it used to be if you want to build bigger, better hotels, you built, the Marriott, you had to build a whole lot of hotels. Well, Airbnb became a pretty good company, just saying, I'm not building any real estate. Warby Parker is a great example. Lens crafters, I hope none of you own stock, but not always the best customer service. So the traditional thing was, I'm going to build, other things in the malls that are better customers. Said, no, I'm not going to build anything. I'm going to do it all online. They can even do your eye exam online, online now. So and Stripe did the same thing for finance. So when he wanted to get involved in healthcare, people said, well, don't get involved in healthcare. It's way too complicated. He started Livongo. And Livongo is a diabetes company that basically said that whole, hey, diabetic people would love to not be treated like a patient. Steve, you can only treat them like a patient. Come to my office, come to my ER, come to my hospital. They became a diabetic person's invisible friend. We were one of their first partners. It got sold 5 years later for $18.5 billion with a B. So Hemant and I got together, with the Livongo thing, and we said, what if a Silicon Valley entrepreneur and a CEO of a 197-year-old academic medical center walked into a bar, got married, and had a kid? What would that kid look like? It's a bad visual if you know Hemant and I, but the fact is we created that kid. And we took our entire digital innovation and consumer experience team at Jefferson, about 30 people from General Catalyst, Silicon Valley, brought in a person from Utah, Dan Goldsmith, to lead a company called Tendo, which is now one of the fastest growing healthcare companies in Philadelphia. And it's a joint venture between Jefferson and GC. So health assurance basically said, what if we start with a model that patients own their healthcare, and created that model and had us have to respond to their needs? what would be the businesses around that? How do we create 100 Livongos? And how do we do it in a way that doesn't just make the wealthy healthier? And the book has basically gone, pretty viral. Everybody in Google has gotten a copy, etc. It's pretty, honestly, of my books, it's the easiest to write because it's just obvious. But I think it was simple enough that people really understood it.
Okay, so we're almost out of time. I'm going to conclude with one question. Last question for you, Steve. But, just on behalf of Withum and everybody on the audience today, I just want to express my sincere gratitude and thank you for joining us today. You've done amazing things for healthcare in and around Philadelphia, for Jefferson, and really for the residents of the community. So thank you very much for joining us here today. And, when you announced your retirement and it hit the wire and I got a bunch of emails and a couple of phone calls and it was the, oh my God, Steve Klasko is leaving Jefferson kind of thing. Need to end here. What's next for you after you leave Jefferson? Not sharing any secrets, but maybe just globally.
Well, look, I've always thought there'd be 3 phases of my career. I do over 2,500 babies. I actually just gave medical school student talk, and one of the medical students walked out and said, my mom said I have to talk to you. You delivered me 31 years ago at Sacred Heart, made me feel really old. But I love that, and I felt I reached pretty much of a pinnacle of that. I got into academic medicine. The honor I've had of being the CEO of University of South Florida, Dean of Drexel, and now doing what we've done at Jefferson. I think this is the perfect time for me to leave Jefferson. In that we've created this thing. I'm a builder. I'm a creative constructor. Somebody's going to have to open up the spreadsheets and run it. I think they'll probably give it to me. And then, and so what I want to do now is really take that. I'm the only obstetrician that's been on the cover of Modern Healthcare and TechCrunch, and I want to really take that ability and horse whisperer thing to really work with the venture capital world, the private equity world, and the traditional healthcare ecosystem to really look at how we make sure the 4th industrial revolution of drones, AI, robotics, genomics is done responsibly. So, I'll be working with companies like General Catalyst, A16Z. I'm going to be doing some work with Sheba Medical Center out in Israel, which is doing some very, very interesting innovation stuff. A company out of Chicago called Abundant Venture Partners that's really done some very socially conscious pieces and really tried to really be in essence, a convener of almost what I've been able to do with Jefferson around health equity and healthcare at any address, and work in my role in the World Economic Forum, and as much as possible bring people together into a consortium of the willing. I want to be a little bit of a Pied Piper for a different kind of healthcare.
Okay, so certainly not leaving this great industry, and more to come from Dr. Klasko in healthcare. Thank you very much, Steve. Really appreciate it.
Thank you, Scott. It's really an honor to be part of this Withum event.
Thank you.
Good afternoon, everyone. I'm Haley Schulman, a senior manager with our firm's healthcare services team. Our first panel session will discuss C-suite and leadership considerations in the healthcare industry. The moderator of the session is Jolene Calla. Jolene is the Vice President of Healthcare Finance and Insurance for the Hospital Association of Pennsylvania, otherwise known as HAP. HAP is the leading voice for hospitals and health systems in Pennsylvania with nearly 240 member organizations. Our panelists include Kathy Bennett, Joe Chiaricella, Lori Herndon, and Daniel Messina. Kathy Bennett is the president and CEO of the New Jersey Hospital Association, which is headquartered in Princeton, New Jersey. NJHA represents all 71 acute care hospitals in New Jersey and has over 350 acute and post-acute members in total. NJHA provides leadership and advocacy, policy analysis, quality and financial data, education, and community outreach. Joe Chiaricella is the president and CEO of Deborah Heart and Lung Center. Deborah is located in Brown Mills, New Jersey, and includes 1 hospital and 12 physician practices. Deborah's revenue is approximately $225 million annually, and the organization employs roughly 1,200 individuals. Lori Herndon is the president and CEO of Atlanticare Health System, located in Atlantic City, New Jersey. Atlanticare includes 2 hospital facilities comprised of 593 beds in total. The system has over $1 billion in annual revenue and employs approximately 6,800 individuals. Daniel Messina is the president and CEO of Richmond University Medical Center, located in Staten Island, New York. Richmond includes 1 hospital facility and 8 satellite offices. Revenue is approximately $275 million annually, and the system employs 2,200 individuals. And with that, I'll turn the program over to Rachel for our first polling questions.
Great, thank you, Haley. Here is our first poll. Did your organization mandate vaccinations? All right, about 15 more seconds. Reminder to please get your votes in, and we will do our other 3 polling questions right after this. All right, 10 more seconds. All right, I'm going to go ahead and close it out. And here are the results. So it looks like 65% voted yes. Okay. On to our second polling question. What percent of your employees are currently vaccinated? All right, 15 more seconds. All right, I'm going to go ahead and close it out. And here are the results. So it looks like 54% of you voted for over 90%. All right, our third polling question for this session. What percentage of your COVID-19 inpatients are vaccinated? All right, 20 seconds. All right, I'm going to go ahead and close this one out. And here are the results. And our final polling question before we begin the discussion. What percentage of your current primary care are utilizing telehealth for non-COVID related care? All right, 20 more seconds. Keep getting your votes in, please. All right, I'm going to go ahead and close it out. And here are the results. All right, thank you all for voting, and we can now begin our first panel session.
Hi, everyone. Thank you for joining us here today. I'm Jolene Calla from HAP, and I know we have a lot to cover, so we are going to jump right in. Just to give you a brief roadmap of what we're going to cover today, there are three broad areas that we know hospital leaders are really focused on these days. First and foremost would be staffing challenges. Secondly would be telehealth, what we're using it for and where do we see it going from here. And then finally, as you heard Dr. Klasko reference, the social determinants of health and how they really can factor in to total care of the whole person. So we'll get started in just a minute, and I will apologize in advance to my colleagues and to the audience because part of my duties are to make sure that we get to each topic. So if we are getting close to time, I may interrupt and move us along to the next one. We do welcome your questions in the chat, and we will have sort of a wrap it all up, rapid fire at the end where each of these leaders get to give you their thoughts on some of the most important things looking forward. So with that, we'll turn to our first area, staffing challenges. And I think we know, even with the vaccine, that this pandemic is really lasting longer than anybody expected. And it seems like when we turn on the TV, we're hearing about new variants and things lasting much longer. So the end is not really in sight. And we know that this is taking a significant toll on the healthcare workforce, who is facing unprecedented challenges and strain on them in ways that were really unimaginable just a few years ago, pre-2020. So with that, Kathy, can you tell us what you're hearing from the New Jersey hospitals and some of the things that are being done to help with resiliency and retaining staff?
Sure, thanks, Jolene. So I think there's no mistake about it. A talented, qualified, engaged, diverse workforce, that's what's at the heart of New Jersey's healthcare delivery system. However, what we're seeing is that hospitals and health systems now, that they're facing mounting and critical staffing shortages, and that could jeopardize access to care in the communities that they serve. For example, NJHA did a survey in October, and preliminary survey data is showing that from 2020 to Q3 of 21, job vacancies for the healthcare workforce increased overall by 13.5%. This increase is in addition to the vacancies that were driven by the pandemic in 2020. So what we saw in the first 3 quarters of 21 are that vacancies for RNs increased by 12.5%. For nurse extenders by 15.4%, and for respiratory therapists by 10.6%. It's just an example of some of the categories. But what we're seeing is that these shortages are expected to continue. There's a Hearst study that says that New Jersey is facing the 3rd greatest shortage of nurses in the US. HRSA is projecting that there's going to be 11,400 nursing shortage by 2030. HRSA is also predicting that by 2025, New Jersey is going to be one of 37 states with a primary care doctor shortage, and we're going to be among a dozen states where the shortfall is projected to be at least 1,000 fewer physicians than what we need. So just think about those two critical areas. And one of the things that we saw is that this workforce shortage, it began long before the pandemic, but the pandemic propelled it into the headlines once again. And what we're seeing is that understanding that an adequate supply of trained healthcare professionals is critical to our healthcare community's goal of providing equitable, accessible, and quality healthcare. These workforce shortages, when you take a look at it combined with an aging population, a rise in chronic diseases and behavioral health conditions, and also those advancements in state-of-the-art care delivery, they all contribute to the need for supportive policies so that New Jersey's healthcare workforce can ensure access to care and be adequately prepared for the delivery system of the future. We've seen firsthand that this pandemic has taken a huge toll on our healthcare teams who have been on the front lines, whether they're in our acute or our post-acute settings. And we're seeing that our healthcare teams are suffering from stress, from trauma, from burnout, and that there are increased behavioral health challenges. With funding from the Robert Wood Johnson Foundation, NJHA has partnered with the Rutgers Behavioral Health to launch the Nurse to Nurse Helpline. No one understands the stress a nurse faces on a job better than another nurse. And nothing has caused more stress for nurses than the COVID pandemic. As frontline caregivers, they have to guard against exposure to the coronavirus themselves. They're witnessing patient deaths. They're worrying about their own family members and friends becoming infected. You know, all of these things come together and increase the pressures that they're under. So in recognition of this unique role that fellow nurses can play in supporting their peers, this confidential mental health helpline, which is staffed by current and retired nurses, we launched it back in October so that nurses and their family members can access that confidential peer-to-peer help that they need. In addition to this approach around whole person that we're working on with Rutgers Behavioral Health, we've seen that many of our members, about 2/3 of our hospitals, are also taking care of the economic health of their workforce. They're offering incentives to staff, from sign-on to retention to referral bonuses. There's a lot of work that's taking place, but we also know that more work needs to be done to close the gap and build the workforce pipeline. And we're working with our colleagues, we're working with stakeholders. We're looking to develop policies and programs that are required for our healthcare delivery system tomorrow.
That's interesting. Is that nurse line, is that available 24/7 or are there certain hours?
It is a 24/7 nurse-to-nurse helpline.
That's great. Joe, I know you had some perspective on this. Can you give us your thoughts on some of what you're seeing on the front lines?
Yeah, I think what Kathy has already shared overlaps a lot of what I've experienced and what we're experiencing, so to speak, at Deborah. It'll come as no revelation to anybody on this attending this conference that staff are fatigued. We're at our highest turnover rate in the 4 or so decades I've been in healthcare, probably double our average. And I anticipate a mass exodus of folks through retirement the next 12 months. And again, I think that has to do with the age of the workforce and the fact that they're pretty burned out. So I think the shortage is going to get worse. I think we all anticipate that. So what can we do to sort of combat or try to minimize that? Well, I think first of all, you need to have a comprehensive support program for your staff. Timely communications are critically important. If you're not communicating with your staff, I assure you the internet and social media will, and the information they get may not be accurate and it may be biased. I think we now realize that. We did not really go to a big work from home strategy early on in the pandemic. Less than 50 employees we had working from home, and it was really more tied to resiliency in case we had an outbreak. And subsequently, we did have some areas where we didn't think staff could adequately socially distance. I think we're going to have to rethink that strategy because in order to recruit staff in the future, I think you need to offer a work from home option. Busy moms, folks that may be qualified but may be too far away geographically, but they may be great candidates for your organization. So I do have the senior leadership team looking at that. I do have to tell you that our entire senior leadership team was here every single day since March of 2020. I didn't think it was appropriate for the frontline providers to come in, put on all that protective equipment and have it go through their mind that their leadership were home in some sort of cocoon and not really exposing themselves to the same sort of risk. I think our employee health team and our infection prevention team have done an excellent job supporting the concerns of staff. And again, that's largely a communication effort, but it has to be backed up by being able to meet with them face to face. And lastly, we have a very robust employee assistance program that any employee can call 24 hours a day. Sadly, even pre-pandemic and currently, it's highly underutilized. But they can call with behavioral health concerns, they can call with financial concerns, or even family issues. It's totally confidential. As an employer, I have no idea who uses it, just how well it is utilized. And unfortunately, I think we live in a society where folks are afraid to raise their hand if they're in crisis for fear that it's a sign of weakness. I wish it was more heavily utilized, but nonetheless, it is there and available to staff. So you need a fully comprehensive program, I think, to try and minimize the impact on your staff.
So I would probably, I'm sorry, go ahead, Dan.
I was just going to add, one of the other considerations is the dividing line between hospital and non-hospital entities. And in New York State, I think we all know that there are mandatory vaccinations. There are medical exemptions. The issue of religious exemptions was a very controversial one that now has been also thrown out. So that did have its impact. So from a policy standpoint, I would just pass on to the audience, be mindful of the decisions that are made and the policies that are put in place and how they affect the external network versus the hospital-based employees. We have over 28 sites throughout Staten Island, and that created, and they're in a separate network. So that created a very interesting dynamic and set of decisions as to how we treat the network versus the hospital-based employees.
Thank you for that. That is a good consideration. I would probably be remiss if I didn't mention the elephant in the room these days, the nurse staffing agencies and the challenges and the use of those. Could any of you comment on, are you using the contract nurses, and how has that played into your operations on both the clinical side, the financial side, whatever you would like to share, I think would be helpful to our audience.
Well, I can start. Thank you for being our facilitator, Jolene. I think most health systems have always balanced their agency temporary staff over the years, and obviously this experience that we're having now, we're using more. I would say we're not using, when you read some of the articles nationally, the situation is much more serious as far as the percentage. We're way below, I would say maybe 5% of our staff, our shifts are filled by agency. So we're not in a position where that's been, so dramatic. They fill a wonderful, role to help supplement our staff. I wanted to just add that what we needed to do, and I think most organizations need to do, is listen to what the nurses need and want. And one of the things they really were very outspoken about is they wanted to have additional nurses scheduled, like one person per shift, to help other nurses. We call it the Helping Hands program. And that has been such an advantage for everyone. The nurse who comes in and doesn't have an assignment, but is there to help. Let's pretend the other people here on the panel are all having assignments for a certain amount of hours to come in and support you. And they get a lot of job satisfaction and a little break from the pressure, as well as then the reverse is I have an assignment and Kathy is the helping hand. She's able to support me and help supplement some of the things that I need to get done. So, I think we've had to go to, using some external support, but I think the message I would want to share is, be creative and look at other ideas around what really would help, supplement your team and help them get through these tough times in the pandemic.
Okay, any final thoughts on staffing or workforce before we move on?
Sure, just real quickly, I was going to take on workforce shortage. I'll say that we continue to survey in these areas, and we have seen that our hospitals and health systems are paying significantly more per year for qualified clinical labor than they did pre-pandemic. And that the big driver for it is the travel nurse. We've seen that the rates have actually skyrocketed. So a survey that was conducted by our CHRO and Sean Hopkins, who's going to be speaking on a later panel today with our chart team, actually showed that hospitals are spending approximately 105.7% more for travel RNs in 2021 than they did in 2020. So, I think what that really talks to us is about, there are varying needs throughout the state, and there are varying cost pressures that are starting to drive on this. And we do need to be very thoughtful about what we do from a policy perspective. I think, that, nurses that are able to take advantage of this, economic, windfall, are, absolutely entitled to do so, and no one's really questioning that. I think what we've got to figure out is, what is, the percentage that is being retained by the travel agencies, just like we do with the insurers. So, we always look at what are your administrative spend, what is it you're keeping for profit, and what's actually going through to the travel nurses, because we only know at the moment what's going into the pockets of the travel agency.
Thank you. That was a very insightful comment. Well, looking at our time, I'm going to move us to our next topic, which is telehealth. And I think we would all agree that the last year and a half or so has, by necessity, really accelerated the use of telehealth services. And reports are that this has been a pretty successful change. Dan, could you talk a little bit about how this has affected Richmond University and what you see for the future of telehealth?
So yeah, we've been making greater investments in our telehealth infrastructure. Although, looking at your survey, we are still right now below the 50th percent in terms of primary care, but we are doing a lot on the telepsychiatry side. That's been a real positive. Our volume since COVID, and obviously we're into this pretty significantly in our market, being one of the hot spots of the 5 boroughs. We've seen that as being a really, really terrific tool to help address the gaps in need and getting people to get the support that they need. So we are continuing to make greater investments. We also have a very vibrant pain program and physiatry. So we're doing more on that front. That sets the stage for lining up procedures, and that's been very, very positive. Clearly, as you see what's unfolding in front of us from a retail standpoint, we're seeing more and more care being lined up to really compete in a really big way with the hospital industry. So that is something that is here to stay. And clearly, in terms of setting up a strategy to really be in the game, I think that's really essential right now for all providers.
And Joe, do you have thoughts on that from your perspective?
Yeah, so I think at the beginning we all scrambled. We were using Skype and Zoom, anything we could get our hands on sort of at the beginning of the pandemic to initiate telehealth. I have a couple perspectives from the perspective of our providers who, being a specialty center, will come as no surprise. They're mostly specialists. I think to a pulmonologist or a cardiologist treating an older population with a lot of chronic disease, not being able to listen to their heart or lungs or examine a patient, didn't prove to be, those telehealth visits just were not as effective, and we found a very high percentage of them flipped into an inpatient visit an outpatient visit anyway. I think from the perspective of the patients, again, it's an older population with a lot of chronic disease. They prefer to come in person. But absolutely, I'm on the same page as Dr. Klasko. We now have a robust telehealth platform. I think for post-procedure calls, well visits, chronic disease management, and I think telehealth platform and telehealth visits are very beneficial. I think we'll see how the reimbursement holds up for them. If the insurers and Medicare and Medicaid start to cut back to pre-pandemic reimbursement for these calls, I don't know that it's going to support the investment we're making in these platforms. Let's hope that doesn't happen. And lastly, I think again, from a specialist perspective, these telehealth visits only work if you've got compliant patients. So we give them a lot of equipment to take home, blood pressure devices, scales to weigh heart failure patients to weigh themselves, glucometers. If patients aren't pretty fastidious about collecting that data and sharing it with us, then again, those visits are less valuable. I think technology is evolving. Right now, we have 5,000 to 6,000 pacer and implantable defibrillator patients that we're tracking every week. Most of those devices are Bluetooth, and the patients absolutely have to do nothing except live a normal life, and we know how they're doing on their devices. And I think as Dr. Klasko indicated, I think these wearable devices like watches and other internal and external monitoring equipment are advancing pretty rapidly and will be collecting data on the fly. Right now, nearly 100% of our sleep patients get a home sleep study first. They get a kit is shipped to them, they open it up, the instructions are very simple and direct. They put the equipment on, which is really not that bulky or complicated, and they sleep in their own bed, and we're able to it syncs up with an app in the morning, and we're able to collect that data and decide, the providers can decide whether or not the patient has to come in for a full sleep study or not. So, you know, I think the future's bright. I think we're all going to be doing more of it. Again, a lot depends on how well we're paid and how well this technology really delivers on what we think it can do in the future.
I think those are great comments, and in listening to both Dr. Klasko and you, it sort of raises in my mind that we are in the midst of a revolution and a change, and it's almost a generational thing, because I think of my 85-year-old mother, and you can have the best technology in the world, and there's no way she's going to use it. She's going to want to go in and she's going to see her heart doctor, and that's it. Where I think of my 25-year-old niece, who she never wants to go to the doctor. She wants to pick up her phone. She wants to have, you know, a televisit on the mobile phone, if that, be able to do everything when it's, you know, her schedule. So it's interesting. We almost have to have two systems to serve the whole population based on what they need. And that gets back to the consumerism aspect that I think Dr. Klasko was referencing. Are there any last thoughts on telehealth from anyone?
I just wanted to say we're handling probably on average about 12,000 televisits, virtual visits a month. And I would agree, behavioral health really adapted, I'd say the quickest. Primary care is probably next. And, you know, it's definitely here to stay. And we're going to continue to evaluate ways to enhance that. And I think it's also taken out some of those, I'll call them wasted visits, where you could have a virtual visit, look at an incision, you know, have a follow-up conversation about a procedure and save everybody time and energy and money. And then just one interesting thing we started a few weeks ago, kind of tying back to your first topic, we're piloting a virtual medical assistant program, which is just, I wanted to share that as just a out of the box thinking as it relates to trying something different in an environment where we were struggling to find enough medical assistants that were skilled to, you know, work in our outpatient areas. And so, you know, that's just a different, when you think about it, having somebody assess, and I shouldn't say assess, but organize that intro to getting into the office and doing that virtually, and then have the MA come in and do the physical things that would be required to get you set up to see your provider. So it's, I think it's going to keep evolving, and I think it's, again, generational. I think it's an expectation that you have virtual options for our patients.
And just a concluding thought, Jolene, as we think about this, and you know, thinking about this in terms of Dr. Klasko's comments about social determinants, this is another area where we do have to worry about it being a social determinant. You know, if we think about it, you know, we know that individuals, and we saw this through the pandemic, particularly when it came time for school at home, they lack the technology, the finances, or the digital health literacy that's needed to take advantage of the promise of telehealth and digital solutions. And so we're going to need not just the healthcare industry, but we're going to need those in the broadband industry to really step up and help provide, you know, what's needed for reliable broadband for, you know, medical care, for school, for work. And we saw this in particular, like that it impacted our Black and brown communities. If you made less than $30,000 a year and you were in an urban center or you were in a rural household, you know, we were anywhere between almost 14% in urban centers and roughly 20% of our rural households not having a broadband subscription. And I'm sure all the clinicians and the CEOs on the call today will tell you that's one of the challenges. That's a social determinant. And it's not one we can solve to. That's one where we need our partners, you know, in the utility side, you know, the broadband side, to step forward and help provide the solution.
Well, that's a great segue into our last big topic, which of course is social determinants of health. And we know things like food insecurity, housing, technology, as you just mentioned, play a huge role in achieving positive health outcomes. So we know that there's a lot of work underway in this area, and I'll toss it to Lori to tell us a little bit about what you're doing on these fronts.
Well, just those people who are on today don't know that much about Atlantic Care. We're a safety net, provider here. We have a variety of different locations, but one of our hospitals is in downtown Atlantic City. So we see all the challenges that any major city would see. And in some ways, I feel like this has been a topic that's been incredibly important for decades. And those of us who have been serving those populations have been working on it. It's been terrific to see the adoption and the awareness grow over the last, I'd say, 3 to 5 years. And then as I think others have mentioned, the pandemic really shone a light on what the issues were for the Black and Brown community. One of the things that we adopted, which is, just would recommend, is you really have to be able to gather some data on what your patients, clients, what their circumstances are. And there's a tool called Prepare, P-R-A-P-A-R-E, which is what we're using in our federally qualified health center and in our clinics where we're serving our more challenged populations. And we also have a tool that we work with the state for, the perinatal risk assessment tool for moms and babies. So getting all those, that information, it's not easy to ask and have those conversations with your patients and clients, but you need to do that so you can understand what their specific issues are, and that you can't just assume that you know. And I guess to frame that out, the areas that we've identified in the last 2 years are really around transportation, food insecurity, and housing. So what we've done is build program and services around that. And just back to want to make a point about the documentation and gathering that. We actually had to implement, if you will, a manager to help us continue to drive that documentation and enhance those programs around collecting the data. So very serious. We're not dabbling. We're making that something that is going to be forward facing for all of our patients. And then just back to the transportation, we worked with a company called Round Trip, which have been really very helpful as far as being able to get patients. I mean, we'll use the virtual option, but to Kathy's point, people that it looks like they have a smartphone, but it is not with any other web-based connections. So you really have to adjust your availabilities to the the individual circumstance. And so still getting people to appointments was important. Food, I mean, I was just at the groundbreaking here in Atlantic City. We haven't had a grocery store in the city of Atlantic City for almost 20 years. So, we've had to do a lot of things over the years to help support our patients, but food and a food prescription and food pantry and food distribution has been really something else. And then just my final point would be around housing. I think I would challenge all of the health systems that serve our communities in the 3-state area to think about housing. I can tell you that it took us about a year to really understand the intricacies for specifically New Jersey. There's a lot of programs out there and a lot of resources to help, if you will, help your organization get more involved with housing. And one of the programs that we started is for our own employees. So employees that would need a down payment to be able to get themselves in housing is something we kicked off this year. It's been incredibly, I'm so proud to be able to be a part of somebody being, owning their first home, and just all the red tape and all the challenges were just, daunting, but to be able to manage that has been just terrific. And we actually have a dedicated team here at Atlantic Care that just works on what are the housing opportunities and what do we need to do to be able to build that capability. And I'm excited about what next year will hold, because we're going to stay on those 3.
So if I'm a provider and I'm just starting to really work on this and I want to get into the housing space, what is my first step, or who is my first call to help me get going to start the journey that you are now well embarked on?
Well, we had to, I had to identify, we reorganized our our leadership team, and I actually have an executive who's responsible for our social determinant work. So that was one step. We couldn't, I saw what we were doing. A lot of we all care, we want to make a difference, but it was everybody's job, so it was no one's job. So having somebody responsible for this, that work, as well as those three major areas that have bubbled up out of our our assessment of what our patients need, and then they went on to go and really do the assessment of all the resources and programs in the state of New Jersey, and there are many. And we'd be happy if anybody is participating today would like to understand how we connected with the resources. Would be thrilled to share that. If you have no place to stay tonight, and you have a chronic condition, or you have a child that's ill, I just, how can you manage, the health needs of the loved ones that you have? So it's such a fundamental need. And, I know many communities are not faced with it, but many are. And, knowing that we can have some, influence and make a difference is what we're trying to accomplish.
Thank you. Dan, did you have some thoughts that you wanted to share around social determinants?
Sure. So a lot of our work began with the DISRUPT project, which was quite a big thing in New York State. Having spent a big part of my career in New Jersey and coming over to New York, it was quite a little bit of an eye opener. DISRUPT really, we had 25 PPSs throughout the state, and again, all driven by relationships that hospitals were building with community-based organizations. So as a quasi safety net hospital ourselves, our ability to do a lot in the food space, in the housing space, in the transportation space, when it came to social determinants, was really kind of filtered through deeper engagement and deeper relationships with many of these community-based providers. So as we kind of proceeded along, we're now completed with the 5-year DISRUPT project. We're now trying to maintain certain projects. So, for example, one of the major outcomes out of that project was to try to deliver more care locally, and to bring care and screenings and primary care to these populations, and really finding creative ways to engage the community. A comment was just made about creating the infrastructure and the leadership to take these initiatives on, and not just spread it out to your existing staff. So we're actually in the midst of creating a community engagement function right now. One of the issues that we continue to be faced with is obviously the opioid epidemic, and on Staten Island it was quite a big problem. One of the things through DISRUPT that we continued to maintain at a fair cost, unfortunately, but clearly we saw the results, was to have peers in the emergency room. So basically we have resources in the emergency room that are former recovering folks and continuing to be recovering folks that will link up with overdose patients and create an opportunity for a higher level of engagement and facilitate a better commitment from these patients. So that was, I think, a big takeaway for us. And then again, continuing to work on projects in the community. We're in the middle of building a low and moderate income housing project. We are going to be the healthcare provider. We're working with a faith-based organization that has made a commitment to bringing some low and moderate housing opportunities to the North Shore of Staten Island. And we were invited to be part of that project vis-a-vis providing the medical services. So, depending on, the organization, obviously it will define the resources that are available to really dive in. But for many hospital organizations, we know what needs to be done. Sometimes it's a little difficult to stretch the dollars in a very complex reimbursement world.
That's a great point, and I've heard that that's where a lot of the partnerships are born, right? Because you can find, you've got the clinical expertise and you can do the warm handoffs to, you know, all of those other folks to help with those resources. But at the end of the day, you know, it does cost money, and reimbursement is a big deal, particularly in government programs. There's not a lot of reimbursement for this right now. I think that that's one of the things that has been talked about at national levels. How do we really get more focus on that and bring that into part of the whole person care conversation? So with that, I'm going to move us to what I guess I'll call our lightning round, because we did focus on 3 specific topics. We know that there's so much more out there, and we do have some of great thought leaders here with us today. So we'd like to give each of you 2 to 3 minutes to touch on anything that you think would be important for the participants on this webinar to know as they look forward going into 2022. So we'll just start in alphabetical order. Kathy, I think you're up first.
Okay, thanks, Jolene. So, you know, I'm really glad we hit upon, like, what I'm going to say are my top, you know, 4: social determinants, workforce, behavioral health, including opioids, and telehealth. But there are a couple more things that are sitting on my list of critical issues. Probably the first and foremost is that this novel virus has upended our world. It's tested our healthcare system in ways I don't think any of us could have imagined. And it's going to continue to do so for years to come. So as we're starting to look forward into 2022 and beyond, what we're hoping to do is move away from these cycles of severe pandemic impact to a phase where COVID is endemic. It's present in our communities, a reason for hospital admissions at some level, but not the source of significant surges of cases, hospitalizations, and deaths, like we've seen here in New Jersey, we've seen in New York, and we've seen in PA over the past 18 months. So we're going to have to learn how to deal with the after effects of COVID-19. So that's sort of top of mind. You know, post-COVID conditions, we know that they include pain, breathing difficulties, fatigue, hypertension, anxiety. What, you know, or some, you know, interesting information that maybe you all don't know is that 19% of asymptomatic patients have at least one post-COVID condition, and 50% of hospitalized patients had at least one post-COVID condition. So we're going to have to figure out how to deal with that on an ongoing basis as we start to move out of our pandemic phase. We also know how costly that this virus has been. If you take a look at COVID hospitalizations nationally among unvaccinated adults only from June through August of this year, it was $5.7 billion nationally. So, you know, we have that big financial hit. We also have seen the cost in terms of lives, particularly the impact it's had on Black and Brown, which has had an even more significant and disparate impact than it has on whites. So, you know, something that we've got to continue to keep front and center in our conversations and in our pursuit of equitable delivery of care. We also see that COVID-19 continues to take a heavy toll on New Jersey's healthcare infrastructure. So we had some really significant financial losses in 2020. We hadn't seen those type of losses in over a quarter of a century, and we're continuing to see contraction in inpatient admissions and in revenue. If we didn't have the federal government there with the provider relief funds, the losses in net income would have been really significant and would have really, for us, I think, had an impact on what our care delivery would look like on an ongoing basis. And what we're seeing is that with the pause in the electives, we've had a very slow return to care. And we're seeing that patient volumes, although they're increasing in 21, they're not at those pre-pandemic levels. We're seeing that patients are delaying care, and when they present, it is with much greater acuity. I've heard of more cases of, you know, wound care that has been greatly delayed and, you know, being presenting with, like, you know, gangrene and whatnot that I have ever heard of before. And then finally, we have that much higher cost of caring for sicker patients combined with fewer outpatient visits. And that's going to be impacting hospital margins relative to those pre-pandemic levels. The other big thing I just want to mention really quickly is the healthcare supply chain, because that still remains strained, with hospitals reporting that, you know, they're feeling it. We're not seeing those major PPE shortages that we saw earlier in the pandemic, but we're still seeing challenges today and on the horizon. We're hearing everything from gloves to surgical masks to infant formula diapers, and then it gets into lab kits, reagents, specimen vials, anything to do with plastics, basically. And then also there's devices that use smart chips because of the issues with the chip manufacturing industry. So we may also see that there's a growing shortage of testing supplies, considering the current and future mandates that are coming out from the federal government as well as state governments. So we know that we're going to need to create supply chain strategies to, in essence, strengthen that supply chain. And I think we're going to have to, reevaluate lean inventory management principles. We're going to have to look at diversifying manufacturing sites as well as sources of raw materials. We can't rely the way we did, during our pre-pandemic on all, foreign made coming into the U.S. We need to make sure that we encourage federal investment and incentives, and we need to have data standards so that we can reduce counterfeit product, and we can also maximize the cross utilization of different component parts. So those are a couple of big things top of mind for me, Julie.
Thank you, Kathy. Moving on to Joe. What do you see ahead?
As we wrap up, first of all, I want to thank the folks at Withum for hosting this symposium, my fellow panelists for spending their time with us this afternoon. I think the lessons we learned from the sort of one side lesson we learned from the pandemic was that because of the significant amount of masking in 2020, guess what? We didn't have a flu epidemic, right? So I just hope the lessons, the takeaways from the pandemic aren't soon forgotten and people revert back to defunding all the surveillance for this stuff, all the development of new vaccines, and subsequently behaviors in the population around maintaining health. I think we live in a society today where things are quickly forgotten. I just hope the government keeps everybody's feet to the fire relative to active surveillance and the continued production of vaccines. I think one of the reasons why there was a lapse also was that the funding, the reimbursement for the vaccines sort of dissipated over time also. And a great percentage of that responsibility started to fall on patients who candidly, in many cases, couldn't afford to be vaccinated for shingles or hepatitis or all the other things we battle with, even the flu. So hopefully that funding will stay around in some of these packages that Congress is considering right now.
Thank you. Dan, I think you're up.
I would, a couple of takeaways that I would leave the audience. And again, ditto to Joe's comments about Withum. Thank you for bringing us together, and thank you for all of the great people out there that have joined us. I've enjoyed being together today. So a couple things, I guess, just, in this world of constantly redefining who you are, understanding who you are and who you're not, the importance of partnerships, and I think more so than ever in this very complex, highly charged environment of healthcare, partnerships really rule, and knowing when you need to think about not creating, things from scratch. I think the vaccination programs that many of us have participated in have created great new opportunities to re-engage our communities. And I will say also have actually created philanthropic opportunities in our communities. So I would pass that on for other organizations to really ensure that they have great new databases to keep re-engage these folks who have come in and trusted us to provide the vaccinations. Surge plans, number 3. One of the unique things about COVID is that, we're all accustomed to having surge plans, but this was kind of the gift that kept on giving, just like Chevy Chase said in Christmas Vacation. It wasn't a single event. It wasn't a plane crash of automobiles or outages or whatever. This was something that just kept coming for months and months and months. So really re-looking at the surge plans and giving that important consideration. Number 4, we became so focused on our patients and our community. I think we have to provide the same focus on our workforce and really think about how to continue to take good care of our workforce. And, obviously, we think about that in our day-to-day, but when you have events like this, it really creates a whole new reawakening around what that truly means. And then last but not least, throughput. Throughput more than ever is critical right now, as policies and our departments of health send down new rulings about elective surgery, et cetera, at least here in New York State. That's a hot topic for us. Give some thought to really a re-emphasis on throughput, especially during periods like this. So, you know, there are thresholds right now, 10% capacity, and if for a 7-day period, you're now going to be thrown into doing a pause on your elective surgery. You know, that's a big deal for us all. That's where obviously we help support all of the other lost leaders. So I would just pass that on as an important takeaway. And those are my comments.
Thank you. And Lori, you can bring it home for us.
I guess my thank you, Jolene, and thank you, Withum. My message would be is I challenge the healthcare industries in this region to dig deep and think very seriously about expanding our behavioral health and our substance abuse disorder programs and services. I feel that that has been another area that has been laid bare with this pandemic and really needs to be invested in. I think many of our colleagues across the region, you know, exited those programs and services because, quite frankly, they're challenging to, you know, support financially. But everything I've seen and believe is going to continue is the epidemic of depression and anxiety and the you know, the abuse disorders that are out there. So something that AtlantiCare is very serious about, and we'll be investing time, money, and energy to try and help improve that those issues in our community.
Well, thank you all, and thank you to Withum and all of the participants. That will wrap up our panel session for today.
Again, good afternoon, everybody. Thank you again for joining us today. For those of you that I do not know, my name is Michael Saluco. I am a partner and team leader in Withum's Healthcare Audit Service Group. On behalf of my Withum partners, as well as the entire firm, I'd like to thank Jolene and the panelists from our first session for a great discussion and their insights. It is now my distinct pleasure to kick off the second half of our symposium by introducing our next panel. This session will address financial considerations in the healthcare industry during these uncertain times, with our guests providing both present and prospective viewpoints. We're very fortunate to have as our moderator of this session, Sean Hopkins, Senior Vice President, Center for Health Analytics, Research and Transformation at the New Jersey Hospital Association. The Hospital Association represents all 71 acute care hospitals in New Jersey and has more than 350 acute and post-acute members in total. Our distinguished panel, as you can see, includes Carl Alberto, Susan Green, Gail Kosler, and Elizabeth Sieber. Carl Alberto is Vice President of Finance at St. Luke's University Health Network. It's located in Western New Jersey and Eastern Pennsylvania. The network includes 13 hospital facilities with a variety of other healthcare-related organizations and joint ventures. They have revenue of over $2.5 billion and currently employ approximately 17,000 staff. Susan Green is the CFO and treasurer at Wellforce. They're located in and around Boston, Massachusetts. Wellforce, includes one academic medical center, Tufts Medical Center in Boston, and 2 community hospitals with 4 campuses. Their revenue is approximately $2.4 billion, and they currently employ about 15,000 team members. Gail Kosler is the Executive Vice President of System Financial Operations at RWJ Barnabas Health. RWJ Barnabas has locations in 8 counties throughout central and northern New Jersey. Their facilities include 11 acute care hospitals and numerous other healthcare organizations throughout its service area. With approximately $6 billion in annual revenue, they currently employ over 35,000 team members. And last but not least is Betsy Sieber, Vice President of Finance and CFO at Doylestown Health, located in central Bucks County, Pennsylvania. Doylestown, is a single hospital system with a retirement community, home care operations, and so much more. With annual revenues of approximately $425 million, they currently employ approximately 3,300 staff. So before we get started on panel session number 2, I'm going to turn it over to Rachel for our quick polling questions.
Great, thank you, Michael. And a reminder to everyone, we will be doing our 4 polling questions. I will leave them up for about 45 seconds to a minute. And remember to please submit your answer. You will get continuing education credit. And with that, here is our first polling question. Did your organization take advantage of the employee retention tax credit? All right, 20 more seconds. All right, about 10 more seconds, then I will close it out. All right, I'm going to go ahead and close it. And here are the results real quick. Okay, on our second polling question. Has your inpatient volume returned to pre-COVID levels? All right, about 20 more seconds. All right, 10 more seconds. I'm going to go ahead and close it out. Okay, and here are the results. All right, and on to our third polling question. Have you issued new tax-exempt debt in the last 12 months to take advantage of the historically low interest rates? All right, 20 more seconds. All right, 10 more seconds and I will close it out. Okay, here are the results. And now we are on to our fourth and final polling question for the session. How many open employee positions does your organization currently have? Twenty seconds. All right, 10 more seconds, then I will close it out. All right. And here are the results of the last question. And it is now my pleasure to turn over to Sean for panel 2.
Perfect. Thank you. All right, so let's go ahead and get started and jump right in. I think before we engage the panelists, what I wanted to do is just maybe take a moment to set the current landscape. Some of those questions actually were valuable in doing that. Shortly after the new year, we're going to be approaching 2 years in a COVID environment. And while hospitals have adapted, we may ultimately need to plan for a new normal. And I think that's what some of the panelists are going to tell us. So let's give you a general sense of what we're seeing in New Jersey, but also some other information that we have from across the country. One of the polling questions that just got asked is actually was interesting to me based on some of the data that I'm about to kind of throw out there right now. But I think it's pretty safe to say that COVID's impact on the industry is going to be long lasting. In New Jersey, we had volume decreases significantly that have not returned to pre-COVID levels. When we look at elective admissions, and by elective admissions, we're looking at the most common elective procedures that are performed in hospital settings: hips and knees, bariatric surgery, pacemaker insertion. In 2020, those volumes were down 26% over pre-COVID levels, and they remain through at least 6 months of 2021. They remain about 26% below pre-COVID levels. We see cardiac admissions in 2021 are 12% lower than pre-COVID levels. Stroke admissions in 2021 are 10% lower than pre-COVID levels, and cancer admissions in 2021 are about 8% lower than pre-COVID levels. Now, if I looked at, pre-COVID is 2019. If I look at 2020, cardiac, stroke, and cancer, those volumes were even more depressed than they are in 2021. So are we seeing a bounce back? Absolutely. Are we seeing a bounce back to pre-COVID levels? Based on the data that I have, we are not. And nationally, a firm called Kaufman Hall, they put out a monthly dashboard, and they're reporting that across the nation, hospital discharges are down 5.5%, length of stay is up 7.1%, and ED visits are down about 9.4%. So significant strain on the way hospitals normally do things. Now, if we look at those admissions that I just talked about, elective, cardiac, stroke, cancer, if we looked at the 18-month period from January 1st, 2020 through June 30th, 2021, that's 42,000 admissions that didn't occur at hospitals. And conservatively, if we value those at what Medicaid would pay for those, what Medicare would pay for those services, we're looking at about $800 million decline in revenue over that 18-month period. So on the flip side, hospitals have experienced unanticipated cost increases that have also placed a strain on hospitals. Between 2019 pre-COVID and 2020, so that now we're looking at the first year of COVID, hospital supply costs in New Jersey increased by about 13.5%, about $660 million. Nursing contract labor costs increased about 18%, and pharmacy costs increased about 10.3%. So when we look again just at pharmacy, drug costs, supply costs, nursing contract labor costs, and we look at those, we're almost seeing the flip. We're seeing an $800 to $850 million increase in expenses that's now being juxtaposed against an $800 million or more decline in revenue. And we're a $25 billion a year industry. So all of a sudden, the drop in revenue, the increase in expenses is about $1.6, $1.7 billion impact. And on $25 billion, that's about 6.5% to the negative that kind of comes right out of the financials. So, as we start to go forward, and again, I look at nationally, so those are the New Jersey statistics. Nationally, Kaufman Hall also reporting expenses are up about 10%, labor expenses up about 11%, supply costs are up about 14%, and purchase services are up about 15%. So all those increases, cost increases and revenue shortfalls certainly took a bite out of hospitals, but for the most part, the federal relief fund has come in and smoothed that over. The CARES Act money, the uninsurance relief fund, the COVID-19 awards, even the Medicare advance payments, all serve to kind of smooth that stuff over. But what we're dealing with right now is an unprecedented workforce shortage, and the realization that COVID may not be going away anytime soon. We have a portal that we built here in New Jersey, and we track hospitals that put in there every day, probably 100 to 150 pieces of information. Back on July 2nd, we had 267 patients in a hospital bed that were COVID positive. And I thought, this thing is about to be over. Where's the nearest bar? I'm ready to go. And all of a sudden, here we are today, as of yesterday's reporting, 1,409 patients in a hospital bed. So that's like a 500% increase over a several month period. We're just feeling the ramifications of Thanksgiving. We've got the Christmas and New Year's holiday in front of us. No more warm temperatures in the Northeast. So I think there's there's more to deal with, and it might be here longer than we think. So this is a CFO panel, and what I want to do is try and get the CFOs to talk a little bit about finances. And so from what we're seeing in New Jersey, it appears that hospitals' bottom lines have actually stabilized, but volume has not returned. And I want some of the CFOs to talk about how those two things kind of fit. And Betsy, we're going to start with you. I think there was an article just recently in the Philadelphia Inquirer saying that Doylestown had returned to profitability. What do you attribute the stabilization of the hospital margin to at your facility? Oh, you're on mute.
Sorry about that. Thanks, Sean, and thanks also to the Withum folks for pulling this program together. It's I'm glad to see a lot of names, familiar names on the attendance list, and it's good to connect with some old friends and maybe make some new ones. So thanks for the question. For Doylestown Hospital, and again, that's what the articles were focused on. For Doylestown Hospital, we did show a bounce back from a loss of about $5.5 million in fiscal 2020. Our fiscal year ends June 30th. And in fiscal 2021, we had a gain for the hospital of about $15.6 million. And without the provider relief funds, we would have shown an operating loss. So, the Health and Human Services dollars that came in the spring of 2020, the summer of 2021, and then we had a third payment in January of 2021. The summer of 2020, it was fiscal 2021 for us. They actually made a huge difference for us. And, without that, we would have definitely had an operating loss. So I guess there's a little bit of a but to this. For us, the provider relief funds have not completely smoothed over. When we look at our impact from March of 2020 with the lost revenue and all the expenses associated with managing the pandemic, those provider relief funds have covered about half of the impact for us. So, the activity has started to come back. We are at about 85% or so of our volume pre-COVID. But as I said, that overall impact reflects an organization that has put our best self, our whole self forward to be able to serve the community. And we've really taken a lot of resources for a very extended period of time. And so that 85 to 90% of our volume certainly has helped, but the extensive losses that we experienced prior to that definitely have not been offset by the combined growth in volume as well as the provider relief funds. So, the other thing that, we saw, and as a matter of fact, John George asked us that question, well, look at the growth in revenue for fiscal 21. Look at that growth in revenue over fiscal 20. Well, 2.5 months of 2020 were at a shutdown mode. So of course, that's why we had such a significant increase. And so, we really do still have that challenge ahead. We've made, a number of efforts to bring our activity back. And, one of the things that was very significant for our organization, we did not do a reduction in force. Our associates were really engaged in the various tasks of managing the pandemic. Our operating room staff were helping in the COVID units and those kinds of things. And that actually helped us to be a lot more agile so that when it was time to ramp up, we were ready to go. And we were able to start to recover that activity a little bit more promptly. Our emergence, most of what we've talked about is that fiscal 2021. We still have those challenges today as we're in past the first quarter of our new fiscal year. We are seeing that our volume is continuing to pick up. Emergency room 30% or so higher than it was at this time last year, which is a trend that we're seeing among many of our neighboring hospitals as well.
So staying on that same theme, Gail, you've got the largest system of the group. You got 35,000 employees. What are your experiences in 2021 related to volume and finances? And more importantly, what are your projections for 2022 and what steps has your system taken RWJ to ensure financial stability?
Thanks, Sean. Yes, and like my fellow panelists, thrilled to be on the panel today, and great to see some familiar names of people who are participating. You know, I think for all of us, we probably all experienced the same kinds of things with respect to volume, and it really is interesting when you think about those cardiac events and cancers and what happened. And what happened to them. And I think that, you know, longer term, we've got a lot of questions to answer about how we deliver care and how we add value to the health of our communities. But, you know, we have similar issues with throughout our system. I think, you know, a lot of the elective services were down in 21. Those have started to bounce back. But, you know, when you get into the question of projection, and I think, you know, even think about this in our everyday lives of, you know, if we rewind back to the beginning of 2020, who would have ever thought that something like this would happen, and the widespread impact that this has had on our lives and our businesses and the way we conduct our services for our communities and collaborate with other people. So, you know, when it comes down to looking into the future at the projections, it's challenging. I mean, I think, you know, last year when we sat down with our board to go over our budget, I said, you know, I've been doing this for decades, and this is the hardest budget I've ever had to put together, because you can't look at historical information and you don't know about the future. You don't know what's gonna return. So I think that we try to think of things in longer increments and think about, you know, where, you know, we still have a strategy. We still have who we want to be over the next 5 years and what we want to invest in. And investing in our patients is primary to us, investing in our communities and collaborating with our communities. So we try to focus on that and set the stage for where we'd like to be over the next few years, and then stack that into a budget that we think is going to be reasonable, you know, reasonable projections for 2022. Try to get some discipline back around some of the things that we used to do, productivity as an example. But I think focusing on the challenges is critical for us. So thinking about that volume, how can we do reasonable projections around that volume, but then also the challenges around staffing. You know, I know we're going to talk more about that, so we'll leave that for that. But you know, as you've heard from the other panelists, and I'm sure everyone in our audience today is experiencing this as well, is there's lots of challenges out there. You know, people, you know, the Great Resignation they call it, but trying to find the staff, and then the staff that you have is at a cost that we haven't seen in the past, and then the supply chain issues. So trying to put all of those to make sense for to stake where we think we'll be in 2022 is quite a challenge. We are seeing volumes come back. I don't expect that they'll come back to where they were pre-pandemic, but we have to think about new ways to provide that value to our customers and our community.
So you touched a little bit on supply chain. Susan, you also have a fairly large system, 15,000 employees, but you know, we all remember the days when everybody was scrambling to get PPE. You know, an N95 mask that might have cost you 50 cents is now costing you $5. Everybody was looking for vents back early on. So it makes perfect sense that in 2020 supply costs increased significantly. But I'm curious about the supply chain disruptions. Are you still experiencing those? How are you dealing with that? What's your perspective on that?
Well, thank you, Sean, and good afternoon, everyone. Susan Green here. And, you know, I think the supply chain professionals across our industry are some unsung heroes of the pandemic. They have worked so hard to outfit and really took it personally when they could not provide PPE to nurses and clinicians across our system. But, you know, we have stabilized since really the hardest times were last 2020 spring and summer. But within 3 weeks of the pandemic, we had to open up a warehouse, 25,000 square foot warehouse right in the middle of our system. And, you know, that will remain open for this foreseeable future. We would have never thought of that in the past. Everything was just in time. We wanted to take the margin or the, you know, reduce margins for our suppliers as much as possible. Right now, we are seeing the hardest, our distributors are putting us on allocation, so you have to plan ahead. We keep about $2 million more in inventory on our balance sheet because of the distribution channel issues. You know, I was preparing for this, and our Senior Vice President of Supply Chain provided some fast facts on the shortage. There are 60,000 truck driver shortage across our country. There are up to 3,000 containers backlogged in Illinois with medical supplies on it, and over 120 ships have to be added in order to reach the supply chain backlog that we are facing. So we've got to plan ahead, we've got to use technology, and it's striking how the shipping industry has caused a lot of these issues to unfold within our system. But the good news is PPE is much better than it once was. We're not reprocessing N95s like we were. I mean, we're giving, you know, a nurse one N95 at the beginning of the day. That's a hard thing in the middle of a pandemic. So really pleased with that. But as I said, unsung heroes of the pandemic are supply chain folks.
You know, yeah, one of the questions that was asked, I think during the polling questions was whether your institution has or has not mandated vaccinations. I want to start, Carl, I want to start with you. You know, give us a sense in what your system has, what position your system has ultimately taken, and both on the for clinical and for back office employees. You know, do you have the same requirement for all? And I'm curious what everyone's experience is with compliance. So, Carl, why don't you kick that off?
All right. Well, thank you, Sean, and fellow panelists as well, and Withum for putting the symposium together. So yes, so here at St. Luke's, we started with our vaccine mandate back on August 9th, and we gave our employees until September 25th to comply with that. And it was right across the board, and it was all employees, even if you were virtual or work from home, we had the same requirement. It was basically for all employees who did not have any exemptions or religious deferrals. They needed to be vaccinated by September 25th. So as of September 25th, we only had about 70 full-time employees and 90 part-time that were not vaccinated. So we were, in essence, 100% compliant with the mandate within that 1 month timetable, 45-day timetable or so. We did grant religious exemptions to about 400 employees, medical exemptions were granted to about 50, and then we had about 200 with a temporary deferral for pregnancy or a positive COVID test within the last year. But then again, you know, we deemed that mandate to be very successful, and the reason for the success was just consistent and constant messaging from our senior leadership, starting with our Chief Executive Officer here, Rick Anderson, our Chief Medical Officer, Dr. Jerry, and our Chief of Infectious Disease, Dr. Mazzetti. So at times it felt it was like almost daily messaging that we gave our employees. But even pre-vaccine, we started the messaging with the PPE and just educating our employees, our staff, and our community on really this is an evolving pandemic and the evolving science around this pandemic, right? So we needed to remain flexible with that vaccine mandate. That's why even towards the last weeks of the mandate, we took in consideration the Israeli study that showed that there was efficacy if you tested positive, that in fact you had some antibodies for that, you know, the next coming year or so. So we did grant that exemption if you did test positive within within the last year or so that you would in essence be in compliance with the mandate.
So just real quickly, and I want to get into the workforce issue in a couple of seconds, but I want to give everybody to have a chance to just kind of comment on that one question. What's the status of your mandate and what's the compliance with it? And so, Elizabeth, we'll start with you. Betsy, sorry. Betsy, we'll start with you, and then we'll go Susan and Gail. Then we'll get into some workforce questions. But I'm curious what other people's experience is with mandates and compliance.
Our experience, Doylestown Health, is somewhat similar to what Carl described. We actually were a little bit early compared to a number of the facilities in our region. Our deadline was October 12th. We allowed a 30-day period for the folks who were not in compliance to sort of give that a second thought and become compliant within that period of time. But from November 12th, they had elected to terminate from the organization if they chose not to comply. And with our organization, the overall health system, 3,500 employed associates, we had in the teens the number of individuals who decided not to be in compliance at all, or decided not to stay is really what it came down to. We of course do have the situation of those who required an exemption, and we work with them as well.
Susan, how about you?
Yeah, so out of the 15,000 employees plus the physician base, which is considerable, we had about less than 200 non-compliant employees / physicians. It was difficult because when you're at a shortage to begin with, and then you even lose a few, it's impactful.
Right.
However, we only provided about 20 religious exemptions, given, all of the research we did, and we got together all our chaplains across the system. They discussed it, and it was very rare for us to provide a religious exemption. So we're pretty proud of it. October 31st was our date. And I think we're now talking about, as TJ Maxx just announced, they will mandate the booster shots. So we're talking about that as well.
Yeah.
Yeah, and similar results with RWJ Barnabas Health. We really thought it was an important message to send to our teams, and we started actually with our leadership team very early on. So people who are in our leadership team were required to get the vaccine earlier, and then we rolled out our employee base as well. But I think for those working from home, it was really important to get the message out there about the importance of vaccines and getting those vaccines. And I think we all see it in the press. The unvaccinated are contracting COVID at much higher rates, and they're a lot sicker. So get your booster. Give my commercial. I think one of the challenges we deal with is for our exemptions that we granted, and we did grant some, those people are required to be tested on a regular basis. And so that is a workflow challenge to make sure people are tested and that their results are shared quickly so that we keep our patients safe.
So let's move away from that a little bit. I said I wanted to get into workforce issues and see kind of what you're experiencing on that front. So, we hear all the stories of workers leaving the workforce, the added reliance on agency nurses. I think somebody referenced the Great Resignation. That's a term now that is kind of out there that's classifying this period in time. But I'm curious, what your experience is with the current workforce shortage and what steps you're taking to alleviate the shortage, both short-term and long-term. And Susan, I noticed I said you've got about 15,000 employees at your organization. What's your current vacancy rate, and what steps are you taking to try and mitigate that?
So nearly 2,000 requisitions are open on a 15,000 workforce base. So over 15% is vacant. And, the actions we are taking are all, it seems, we closed our budget out for our fiscal year 2022 2 on October 1st, and we told our finance committee member, of which one of the partners at Withum is, volunteers his time, Paul Badaro, really great finance committee member. We're going to bring back a reforecast, and we're going to continue to do that on a quarterly basis because of the dynamic staffing market. But we've signed agency contracts for over $200 an hour for a nurse, and when they go into overtime, it's almost $300 an hour. Rates, astronomical rates that are just not sustainable. So we're doing $10,000 sign-on bonus, referral bonuses. Our cost of living increases are up to 3%. I don't think that's going to be enough to get it done. But we're really trying to look at what we do and create digital solutions so that we can replace some of the workers with technology. We're going to have to do that more and more in this environment. Call center staff is impossible to find right now. And we're paying almost $36 an hour for call center staffs. So it is a critical time for us. So we've got to make our workplace a better place to work and to practice so that people want to come join us, but use technology to do it, and just a better talk to our employees a lot more, engage with them so they feel a sense of pride and ownership. But it's going to be a rough couple of years, and we're going to have to plan this and forecast it throughout the throughout the next several years.
You referenced agency nurses getting well in excess of $200 an hour, but it's not just the agency nurses that are hard to come by, but frontline staff are also at issue as well. Betsy, what's your experience with frontline staff? What are you doing to try and retain them and keep that workforce stabilized?
So we've been having similar challenges, and one thing that we did, which is we decided to take a significant step for our associates in order to be able to recruit, attract, and retain folks. We took a good look at our average hourly rate and wage rates for those frontline folks, and we did an evaluation. And honestly, I was in a meeting and somebody said, "Is that the CFO saying, yes, this is a good idea to spend more money?" But, to me, it was, I agreed as well. It was really important to make sure that we pay a fair wage. And we evaluated the rates and started to consider, how about if we phase this in? What would that entail? How many people would be impacted? And how long would it take? And what would the cost be? And what we realized is that most of the gap was in a much smaller number of people. And it really, what we found is we could affect a lot more individuals and families incrementally with not as much of a cost either as we started to look at it. The gap was very significant, kind of focused in certain levels of the organization. So we made the decision to do it all at once. And we brought our lowest rate or minimum amount up to $15, and then we also rolled out, address the compression issue so that other folks were affected as well. And we made the decision to do that all at once, so we did that in September. We're starting to really see the impact of that, and we also recognize that it's not over.
Yeah, definitely. It's not. I think we're going to be dealing with this for a long time. So maybe we'll move away from COVID just a little bit. For those that are participating in the symposium and got to see Dr. Klasko in the early part of the program, he talked about private equity coming in and mergers and acquisitions. So Carl, I'll start with you, and then Gail, I'm going to go to you after Carl. But moving away from the COVID perspective slightly, what's your perspective on merger and acquisition activity? Do you see it declining or picking up steam? Do you anticipate FTC oversight that will ultimately ease or become more stringent? Which direction you see that going in? What are the benefits of merger and acquisition? And do you anticipate private equity investment becoming more prevalent in the future? And I know, Carl, you've got a system that kind of spans 2 state lines. So I'm interested in your perspective first. And I think, Gail, there's a few things that are still in the works for RWJ. And so we'll get your perspective after Carl. Carl?
Right. Yeah, I would think that M&A activity will continue very much so. Whether you're a sole provider or maybe a small system, there's always opportunity there to leverage the value of joining perhaps a larger enterprise. And certainly at St. Luke's here, sort of part of the formula to our success has been to be able to select small community facilities, small community hospitals that have strong community support from the residents, and go ahead and have a partnership with those facilities. We don't call them acquisitions, we call them partnerships. And we've been very successful, starting back in the 90s with Quakertown, and then even with my former facility over in Phillipsburg, New Jersey with Warren Hospital. And we've grown our market share significantly in our primary service area by doing what we refer to as smart strategic growth. And there's a lot of value for the facility that's being acquired because you obtain access to capital, but there's different forms of capital, right? There's certainly there's financial capital, but there's also intellectual capital. There's the medical staff that you're able to integrate through the various campuses and bring in multi-specialty services that your community didn't have access to previously. And we believe, and we continue to believe, that there's significant value to those communities that we partner with. And whether it's in Phillipsburg, New Jersey, or whether we're right here in Allentown, Pennsylvania with Sacred Heart Hospital, which was an urban-like center that we acquired back in 2018. Blue Mountain Hospital in Lehighton. There continues to be a significant amount of value and investment that the system makes in those communities, and in return we have incredible support by the community, and that explains why we've been able to grow market share in the last 10 years, about 66%. We went from about 34% market share in our primary service area to 55%. And it's with these strategic alliances, strategic partnerships with the smaller community facilities.
So Gail, how about you? You're one of the two largest systems in the state, and it seems like as every year goes by, each of those two systems seems to gather another hospital and get a little bit bigger. What do you see the future of merger and acquisition?
Yeah, I mean, Sean, thank you. I don't think it's necessarily about getting bigger. I think it's really, relevance and, providing services in a high quality, high value way. And sometimes that means working with a partner to bring about an expertise or capability that we don't have. And I think that can take a lot of different forms. I mean, it may be a hospital, but it could be some other equity partnership that provides expertise that that's their niche service, and they're really good at that. And it harkens a little bit back to the previous conversation we were having about finding necessary resources in our workforce. And we talked a little bit about the high rates for back office. Sometimes bringing a partnership together can alleviate some of that because you're working in the same network and in the same system. So I think that that's a benefit to it. But we really, again, try to focus on the high value, high quality services, and a lot of times that involves a partnership. Dr. Klasko mentioned, he talked about, I guess he was asked the question with respect to FTC approval, and that if you're looking for something that was providing better care at a lower cost, then you have a business proposition there that makes sense. And I know we're moving away from the COVID discussion, but those volumes that we lost in COVID may not be coming back. And so we need to think about new ways to deliver care. And I think that's what partnerships bring us. And many times those partnerships are not equity partnerships at all. They're relationships. And I think, we all learned that during COVID, working with our community, working with other hospitals in our community towards, the betterment of our patients' health, our community health. I think they all work in our favor.
So I'm gonna, Betsy, I'm saving you for last because you're the unique player in this group as a standalone facility. But Susan, why don't you just give me 30 seconds to a minute on your perspective on the future of mergers and acquisitions, and then Betsy, I'm going to come to you and talk about the future of a standalone hospital in this very competitive environment. So Susan, let's start with you first.
Yeah, we are seeing an uptick in activity of receiving requests for proposals, not only from acute care facilities, but large multi-specialty group practices that were hit hard by the pandemic. You know, they had to close their doors basically during the height of COVID. So we are seeing an increased activity there. And clearly, you know, you just don't grow to grow, as Gail said. It has to be something that makes sense strategically. It has to deliver value to the member. You know, just in terms of our merger over the last 5 years, we've saved over $255 million from, you know, all sorts of areas, from cost of capital to supply chain to, you know, integrating corporate services and the like. So it's got to make sense, but we are seeing an increased activity. You know, Massachusetts we have 2 very large systems, and MGB being Mass General Brigham is over I think they're close to 15 billion, but only several hospitals, much bigger hospitals. And then BI Lahey. So they have 50% of the market share in the Boston area. So I don't think they are able to grow very much more. So that's important to think through as a state, because, you know, it has caused prices to increase in the Commonwealth.
So Betsy, I saved you for last. So in New Jersey, we probably can count the number. We have 71 acute care hospitals. We can probably count the number of standalone hospitals on both hands, and I don't think you're going to need all those fingers. What's Doylestown's perspective in this environment, and do you see yourself? Is your board basically saying, "Hey, we're a community hospital, and we're going to remain that way," or at some point does the need for capital investments and you know, negotiating leverage in managed care contracts, does that kind of outweigh it? Where are you guys at, and what do you see the future as far as Doylestown's concerned?
So this is a question that the folks from the rating agencies ask us quite often as well. You know, and kind of everyone sort of looks at us and wonders why and when, right? So part of the why is our board and our community is committed to this organization. We have honestly a very generous community in terms of donors and those who have really made a commitment to supporting the organization through their generosity. So that's one of the things that we're working on. We have an advantage. We have had an advantage, especially during the pandemic, to be much more agile, to make our decisions much more quickly, to change clinical protocols and so on very rapidly, and not being part of a health system infrastructure. So I hope that doesn't make me sound so insular, because we're not. One of the things that we identified is, you know, and we certainly have done for decades now, is make sure that we have good, solid partnerships. And Gail kind of talked about that. Those partnerships are not necessarily equity ownership or being, you know, a merger, but we have clinical partnerships with a number of different organizations where we do a lot of work with the Thomas Jefferson University Health System. We have Penn, University of Pennsylvania Medicine on our campus for radiation oncology. We have Moss Rehab on our campus, which is you know, the best in the business in terms of acute rehabilitation services. Moss is part of Einstein Health, which is in turn part of the Jefferson family. And you know, we continue to foster those relationships. And we also, you know, continue to work with organizations. How can we partner? What is it that we can share? What can we do together? We have cardiologists who are providing services in 2 other facilities in this region to really rely on the expertise that's here. And, you know, we continue to work on how we're going to build those ideas and develop those concepts.
You know, it's again, each hospital is a unique entity unto itself with its own mission. And so there's a lot of different ways to serve the community. All right, so I think we've got probably about 4 or 5 minutes left, and I wanted to touch on one other topic, and that was telehealth. COVID really accelerated the use of telehealth services. I'm interested in getting your perspectives on telehealth. We heard Dr. Klasko say, I think at one point they were getting 50 telehealth visits a day, and then it moved up to 4,000 telehealth visits per day. So he was really a champion of that. Are those services making money? Do you see them ultimately expanding? Want to get each of your perspectives on that, and we'll go kind of like in reverse order. Carl, I'll start with you, and then Betsy, Susan, and Gail, and then we'll see if Rachel's got any questions in the queue.
Sure. So pre-pandemic, right, pre-COVID, telehealth was certainly out there, but it was almost like a well-guarded secret. Not too many folks knew, within the community that it was available. And I recall March 15th, March 16th, the world changed because we went from about 1,000 visits per month pre-COVID to, at the high watermark, was 90,000 visits per month here at St. Luke's. Obviously we have over 300 sites, outpatient sites. I think telehealth, is here to stay. We did have a dip, so we went from 90,000 down to about 37.5 in December of 2020, as most of the folks here experienced the same rebounds in volume in the second half of 2020. Our volumes went back to pre-COVID levels right about December or so 2020. As it relates to specifically to telehealth visits, last month we're at 12,500. So compared to the 90,000 high watermark, it did come down considerably, but it's here because the consumer is aware very much that the service is available and it's highly convenient, right? Highly accessible. And to Gail's point earlier about value, this is a value-driven industry, right? The consumer is demanding value, high quality, low cost, easy access, and that's what telemedicine is. And it's not going away. It's going to continue to expand. I think technology to enable that continues to evolve as well. We just opened up our latest facility here in Carbon County, our Carbon campus, 3 weeks ago or so. And every patient room is equipped with state-of-the-art monitors to have virtual health. So you can have consults from anywhere in the world. Specialists have bedside consults with those patients that are inpatients. So it's here. I don't think it's going anywhere. In terms of the profitability, initially there's a significant amount of investment in that you have to make in telehealth, but eventually there's a significant return back to the organization as well. So it's a smart investment, and more importantly, it's what the future will dictate, basically.
Yeah, I think it's here to stay, that's for sure, and it needs to be figured out a way to have it maximized. So I think we're getting a little tight on time, so I'm going to make it a little bit of a flash round. So Elizabeth, quick comments, and then Susan and Gail, quick comments on your perspectives on telehealth.
Definitely here to stay.
Susan?
Here to stay, and I think we would benefit for behavioral health immensely if we could expand that capacity. That is a great solution. Telehealth is a great solution for behavioral health.
Yeah. Gail, how about your system?
Yeah, I think from a financial perspective, like you can't look at a service like that on a transaction basis and say that that's a profitable business, but it's really about adding the value, as Carl reiterated. It's about adding value to patients. And just throw one personal experience in there. I had a family member who was able to receive some behavioral health services recently over telehealth, who she would not have gotten the services had it not been for the capability. And so I try to keep that in mind when we offer these services. That could be my family member or me looking for that.
Sure, absolutely. It certainly makes for ease of access, that's for sure. I know over the pandemic, I needed to see my primary care physician, and they said, I called the office and they said, fine, let's just set up a video chat. And he asked me a bunch of questions, and there it was. So, but it was interesting as the pandemic started to kind of wind down. If I called up to make a telehealth visit, they're like, "That, come on in." So anyhow,
got
so
some tests for you too. We have some tests for you too, right?
exactly.
There's a scan.
All right, so real quick, Rachel, I don't know if you're out there. I don't know if we had any audience questions. I know we're at 2:23, and there's another panel that's going to start up at 2:30. So absent any questions, and I don't see Rachel kind of popping onto the screen. Absent any questions, oh, there you go. Any questions, Rachel?
Sorry about that, we do. And if we can answer it quickly, just so we can have a short break before our third session, that would be great. What about New Jersey and Governor Murphy's pushback on making temporary telehealth permanent?
I think it's great.
Yeah, what a break. Thumbs up.
I think from the clinical perspective, I think you're going to get a lot of support for that, because it means it's an easier means to get care to patients that need them, whether it's behavioral health or primary care.
Absolutely.
Great.
All right.
Thank you so much.
So, Rachel, there's no more questions. I'm going to turn it over to you or Scott. I just want to thank the panel. Hopefully one day soon, we're all going to be reminiscing about how COVID once ruled our lives. I know everyone's going to be happy when we start to refer to it in the past tense, but it's here to stay, and that's what we all signed up for when we chose a career in healthcare. And so we just have to keep our foot to the gas pedal to the floor and get through this. And I want to thank everybody for all the insights that you guys provided today.
Thank you.
Thank you all.
Thank you.
Hello, everyone. My name is Anna Romeo, and I'm an audit manager in Withum's Healthcare Services team. And first, I would like to thank the moderator and panelists for the terrific discussion we just had. Our third panel session will focus on cybersecurity in healthcare. So at this time, I'd like to give a warm welcome to our moderator and our panelists. Moderator of this session is Matthew Ferrante. He is a partner and the market leader of cyber and information security services at Withum. Withum has about 19 offices nationwide and internationally, and at $350 million in revenue has over 1,500 employees. Our panel today includes Roger Lathrop, Tom Pasek, and Jim Robertson. Roger Lathrop is the Senior Director of Internal Audit and Compliance and Privacy Officer for the Guthrie Clinic. Guthrie Clinic is located in Sayre, Pennsylvania, and is an integrated health system with 5 hospital locations, multiple physician clinics, home health, hospice, and other entities. At over $750 million in revenue, there are 5,300 employees. Tom Pasek is Vice President of Systems, Integration, and Technology of Inspira Health Network. Inspira Health Network is in southern New Jersey, about 20 minutes southeast of Philadelphia, and has 3 hospitals, over 150 locations. At revenues, approximately $900 million, and employs 6,800 individuals. And finally, we have Jim Robertson, who is partner and chair of the healthcare department at Greenbaum, Oak Smith, and Davis LLP. They're located at 4 offices in Woodbridge, Roseland, and Red Bank, New Jersey, and one in New York. At revenue of $45 million, it has about 180 employees. So at this time, I would like to turn the program over to Rachel for our final 4 polling questions.
Great, thank you, Anna. So again, these are our last 4 polling questions. I will leave them open from 45 seconds to a minute, and just be sure that you are answering them in order to get continuing education credit. And here's our first polling question. Does your organization have proper cybersecurity measures in place? All right, about 20 more seconds. All right, 10 more seconds, then I'll close it out. All right, I'm going to close it, and here are the results. It's like 83% of you voted yes. On to our second polling question. How concerned are you about hackers attacking your organization? All right, 20 more seconds. All right, about 10 more seconds and I'll close it out. All right. And here are the results. So 50% of you voted very. So it's good we are having this discussion. Third polling question. Does your organization use multi-factor authentication across all of your systems? All right, 20 more seconds. All right, 10 more seconds and I'll close it out. Okay, here are the results. 56% of you voted yes, which is great. And our fourth and final question. What do you think poses the biggest risk? All right, 20 more seconds. All right, 10 more seconds and I will close it out. All right. And here are the results. 70% of you voted unused laptop laying around the office, which I believe is the correct answer. With that, I will turn it over to Matthew to begin our third panel session.
Great, thank you, Rachel. I'm very excited to be here today, and it's a real pleasure to be the moderator today for some very experienced panelists. Cybersecurity, as everyone knows, is a very hot topic. Today's modern cyber threats are getting more pervasive and sophisticated, and critical impacts are occurring left and right. Cybercrime damages, case in point, cost approximately $6 trillion globally. Threat actors are targeting healthcare critical infrastructure. For our audience, keep in mind, although ransomware attacks make great headlines and occur approximately every 11 seconds, they are not the only form of cyber attacks that can cause critical impacts to vital healthcare networks, systems, and data. All right, let's begin and get our bits and bytes on with our first panelist question. And that's going to go to Tom, who is a VP for Systems Integration Technology for Inspira Health Network. Tom, how serious of a challenge do you believe cybersecurity is for Inspira Health Network? What are some of the cyber risks that keep you up at night? And for the audience, please elaborate on what is truly at stake in today's modern cyber threat landscape.
Well, nice question to start with. Thanks, Matt. Well, cybersecurity is huge at Inspira. I mean, for any organization, it's got to probably be one of the #1 issues at every single organization, whether it's healthcare or not. I can tell you the importance of cybersecurity at Inspira is, you know, we engaged a new audit company, internal audit company, and of course, the very first thing they went after is the cybersecurity program. And honestly, they were told by the leadership in our organization that that was the #1 issue that should be audited. So it's critical. It's really, really critical, and it's challenging for our organization because resources are tough. Resources are tough to come by. And I'm not talking financial resources. I'm talking about people. It takes to put the programs in place, to put the tools in place. It takes resources to do that. So that is a real challenge for us. I think that keeps me up at night for sure. But really, you know, in healthcare, we're about patient safety. We're about taking care of patients, making them well. So the safety of our patients. So interruptions of service to our systems is critical. It can cause a patient safety issue. It can cause a bad outcome. It's a huge risk for us. Corruption of the data as well. You know, if the data is not accurate, somebody gets in there and changes a number or something like that on us, could be also life-threatening. And then, of course, maybe a little less severe, but the loss of data. You know, somebody holding your data at ransom or threatening to share, share data publicly. Again, it's an interruption to our business and our operations. Today, the modern day stuff keeps growing. I mean, all the mobile devices, the Internet of Things, all those things, every single thing that touches the internet, and absolutely creates an exposure for us and a risk. And so those things continue to grow. So the task of keeping things safe also continues to be a bigger challenge every day. The bad actors are out there. They're getting us more sophisticated as well. When they started these things, they were on their keyboards hacking away, trying to get into our systems. Now they've written programs to do that. So they don't even sit at the keyboard. It does it for them. They got bots out there doing these things. So it's serious. It's a challenge for all industries, especially healthcare, because of the patient safety issues as well. God, I guess I think the thing that we need to keep in mind, though, is we're never going to be 100%. And so what we need to do is, with our security program, it's all about acceptable risk. How do we get to a point where we have acceptable risk that we're willing to live with? And so that's what we do with our security program, and that's what we manage to on an ongoing basis.
Hey, excellent, thank you. Roger, same question as Tom. You know, is cybersecurity for the Guthrie Clinic a major concern? And if so, why should the audience be concerned? Also, I want you to do it from your role as an internal audit and compliance. What do you see as some of the biggest challenges in relation to cybersecurity?
I'm glad Tom got that question first so I could hear his thoughts, and then I'll just sound like I'm just glomming on. But I totally agree with Tom, and from the standpoint, is it important? It's absolutely important. From our work plan for the year, we put it as our #1 risk based on cyber risk assessments, and and I'll agree again with Tom that there's those situations where ransomware is not the only problem. Denial of service and things such as that, the Internet of Things scares the life out of me from the standpoint of, could somebody hack in, change an IV pump, kill a patient? You know, that's the probably the most terrifying end of it. And so it's really important. I think the #1 thing that's a problem for me is staff education. How do you make it real for those folks, and especially the people that may be at the highest risk? As Tom had said about the bots and things, they only have to get it right once, and our employees have to get it right every single time. And so the odds ratio is not there. And so how do we train our folks? What tools do we give them to work on that? I think one of the big initiatives for us in internal audit is trying to get the funding. I think Tom was spot on about getting people. That's difficult, but it's also tough when you have to buy MRIs and other things that directly affect patients to try and come up with a percent that we might get hacked, and this is what it might get cost. The organization is a little bit in the weeds for some high-level administrators. They really know that if they buy a CAT scanner, they can do X amount of tests per year that equals X dollars and X patients served. So I think that's a challenge that we have. On the internal audit side, for us, it's about trying to catch the people who are doing at-risk behaviors, using those education programs that will tell us who's at risk. One of the things that we were able to do, and it actually took it off the list of things that keep me up at night, is, and I'm not to mention any names of programs, but we use an iron scales program, and folks may have that out there. And that's really been a eye-opener for us and a great tool for the staff to report what they think could be phishing or cyber events related to email. And it's also been a great tool for us to be able to go back to management and say, here's 10,000 attempts a week, and here are the top users. And actually, you're able to go back to those users that they're trying to get, the finance, the CEO, the pharmacy director, you know, those folks, and legal, of course, and talk to them about, you know, you guys are a target. This is what it looks like. So I think those things, and then of course balancing access and security. That's probably the biggest part, because everybody needs access to do their job. And how do you say what Tom had said, that you got to be able to provide them with enough access, but enough security to protect the patients. So that's a really good question. Really gets the brain flowing.
Thank you. Okay, and there's a general consensus across cybersecurity experts that it's not whether if impacts will happen, but when critical impacts are going to happen. So Jim, or counsel, because I'm used to dealing with a lot of incident response. So counsel, across all sectors, especially healthcare, we're really seeing cyber insurance premiums skyrocket. Why is healthcare seeing the largest increases in premiums? What advice can you provide the audience and healthcare providers to get affordable cyber insurance? And with that said, the other thing that I want you to consider as well is, perhaps more importantly, to ensure that that policy has real value when critical cyber impacts occur.
Yeah. Well, I'm here to tell you, and you probably already know this, but healthcare is a very unique industry. You know, when your computer systems don't work, sick people don't get treated. That's the end of the game right there. And hackers know that. And they know that healthcare entities probably are more willing to pay ransom to get their systems back up and running, rather than go through a lengthy restore process. You know, healthcare as well has historically been focused on investing in new technologies for the benefit of the patients, not necessarily to secure medical records. I have some clients who are still using paper records, believe it or not, in terms of the medical record. So, you know, the health systems are collecting patient data and taking observations, turning them into data, often very extremely sensitive data, hundreds of thousands of people, maybe millions of people every day. So the data is a very valuable asset, especially on the dark web. You know, the medical, we talked a little bit about the Internet of Things, just so everybody on the program knows what that is. You know, you have devices that have embedded versions of firmware in them. And when you take them home, they're hackable. Wearable health monitors, for instance, is a good example of that. So the Internet of Things pose a greater, you know, risk to healthcare entities when people take these devices home. And a lot of times, sometimes you have out-of-date firmware that has been loaded on these devices, you know, so you have to get updates. Now we have the pandemic, right? So workforces have migrated from working in the office to working at home. And that presents additional challenges and also advantages for hackers. You know, there could be unsecure connectivity, there could be employee access issues, phishing and social engineering schemes that go on and people fall prey to. So taken together, Matt, you know, the urgency to have your systems up and running to save lives, the lack of spending on cyber defense because you've been spending your money on improving your technology for patient care, the presence of outdated firmware, and the migration to work at home settings creates the perfect storm. So insurance companies know this, and that's why your premiums are rising. In fact, they're rising at a tremendous rate. Year over year, you're talking about anywhere from 10 to 30% increase in premiums. You have a greater demand for the policies. Over 4 years, the demand for cyber policies has doubled from 2016 to 2020. You have insurance companies who are reducing their coverage limits. You can get them for $500,000 up to about $5 million per occurrence. But what I would recommend, and in terms of insurance, what I would recommend is a standalone policy. Do not anticipate that the policies that you have, D&O, maybe errors and omissions, but maybe not, but your general liability policies, that's not going to cover this. You need a standalone policy. You have policies that are offered that offer network security and privacy liability coverage. So network security coverage, for instance, they're first-party costs, which are expenses that you incur as a result of a cyber attack. So if you need your legal expenses covered, your IT forensics, when you negotiate a payment of ransomware demand, data restoration, breach notification to patients, setting up a call center, public relations expertise, credit monitoring, or something like that, that network security coverage should cover that. And then you have privacy liability coverage, which is really more of a third-party coverage for those claims that people make if you have to defend a patient class action lawsuit, for instance, as a result of a data breach. Legal expenses and fines that you have to pay to a government entity as a result of an investigation or enforcement. All of these policies, that standalone policy is something that every organization should be looking at, but there are going to be exclusions too. You're not going to get coverage for future lost profits. You're not going to get coverage for theft of intellectual property necessarily. You're not going to get coverage if you have to improve your system as a result of responding to an attack. And then you've got the acts of war exclusion in policies now, which is becoming a really important exclusion because we have foreign actors out there that are hacking systems, and there's a lot of litigation on this right now. We haven't had a case that has actually decided whether an act of war exclusion would exclude coverage in the circumstance, say, if actors from Iran or Russia infiltrate your system and you have to respond to that. Is that an act of war or is it not? That has to be decided. So anyway, I would recommend that you get a standalone policy, Matt, but in all honesty, you can have all the insurance that you want. Really what you want to make sure is that you've got good network system security and defenses. No, not good, great network system security and defenses, okay? Make sure your backup restoration and disaster recovery systems are tested and tested often. Make sure you've got a good HIPAA privacy and security plan, and we can go through the elements of that. I don't think this audience needs to know the elements of it, but you have to have one. It's got to be robust, it's got to be good, and it's got to be ready, and people have to know, they have to be trained on it so they know what they need to do in the event of an attack. If you have those things in place, it will help with the premiums on your policy. It will help you get coverage. And then you get your coverage in the event you have the catastrophic situation where you need to get coverage. But don't get the policy and not have a good defense and security system. That's not going to work. Anyway, I hope I answered that question.
No, you did. Thank you so much. A lot of great input on that. I always use just one of the things I think that should be added to that. I agree with the great defenses, but one of the things I always say is Noah built the ark before it rained, not after. My suggestion would be that it is reviewed by council prior to critical impacts happening. What I do see on the incident response side is a lot of people suffer the impacts, then they dust off their policy and they find out what it includes and what it doesn't. So definitely getting that legal advice prior to and reviewing that policy, I think, is critical. Okay, and you touched on IoT devices, and next up is Tom. We talked about medical devices being increasingly interconnected into the healthcare network environment, that these devices are notoriously insecure. For the audience, there's about 34 billion internet connected devices. It makes up about 2/3 of the internet connected devices. So for Tom, how does Inspira Health Network address these risks of IoT devices, whether through segmentation or other type of means? Further, do you feel you have any substantive leverage over the suppliers of medical devices and IoT devices to ensure they're HIPAA compliant and/or secure?
Great question. We do use network segmentation. So we do segment the network, and for those on the call, that just means that part of the network that we run all the other corporate business on is separated logically on the network, so that the medical devices run on basically like a separate piece of the network. So if they get compromised, that does not, the hackers cannot get into the rest of our network system. So any of our EMRs or any of those things. So that's one thing we do, and that's just minimizing the physical risk that happens on the network. It becomes more of a challenge when you have the medical devices now gone home to people's homes and trying to protect that information from coming in. And we honestly have not figured out how to solve that one yet, but that's one that's going to be high on the list in 2022 to try to figure out how we best protect ourselves from those devices, because we're sending more and more people home with medical devices to continue to monitor them. That happened during COVID in particular. It was a good way for us to be able to free up beds for more patients that were more severe, more complex. So we were able to send people home a little earlier that had COVID on medical devices. So, and that trend just continued to grow. We have a Philips, we at Inspira have a Philips contract for management of our medical devices and services. So that gives us a little bit of an upper hand over most health systems that don't have something like that. You know, we have one company that we can turn to that will, especially their devices, which is the majority of what we have in our organization, they will keep their devices up to date. They're very good at that. They've gotten much, much better. They will patch their devices, they will upgrade their devices, any security vulnerabilities, they take care of that pretty much immediately as they identify those. So that's a good thing for us. But that doesn't happen with all medical devices. There's a lot of medical devices that come out, and to Jim's point earlier, you know, the firmware is outdated. They don't keep their software up to date. They're getting better, but they are so far from where they need to be from the other application vendors that we deal with in the healthcare space. So what we do is we use a vendor security management program. So we identify those, we rack them and stack them. We go through basically a questionnaire and an assessment of how good they keep their software up to date, what their policies are, their access to their equipment, all these things, and we rank them high, low, high, medium, and low. And then we try to identify the vulnerabilities and work with them to remediate whatever the high vulnerabilities are, and then work our way down. So that's the best we can do right now. It is getting better, but to Jim's point, there's a lot of equipment vendors out there that just, they deliver a medical device, and some of these medical devices, they're in our network for years. 10, 15 years, this equipment just works. So they don't do the updates and the security updates that are necessary. And so they're getting better at it, but it's a full-time job just to keep on top of these vendors and make sure that that equipment, again, the best we can do is segment it so that if in fact something happens, it doesn't impact the rest of our operations.
Okay, great, thank you. And Roger, I'm going to get to you from another perspective, but I want to jump, since we're on topic of IoT devices, back to Jim real quick. What potential liabilities does a healthcare provider have in relation to these devices, especially if such devices cause critical impacts? Killware, for example, is a type of malware that is being deployed with the sole intention of causing physical harm, even death. This type of malicious malware is being developed by nation-state actors as well as pretty much cyber psychopaths that cause physical injury and death. And this is in vaporware. This is the reality of today's cyber climate. What can healthcare providers do to reduce risk to patients as well as limit their liability in relation to these critical risks? For example, if a medical device is not HIPAA compliant and the device is not secure, who is liable for that device, especially if it causes a significant impact, including potential death or other type of critical impacts?
Yeah, you know, if killware doesn't keep you up at night, I don't know what will. You know, think about it. You know, recently the Department of Homeland Security designated killware as an emerging cyber threat, even more urgent than the typical ransomware, where people will routinely now, in over the next several years, weaponize operational environments to intentionally try to harm and kill people. Okay, that's what we're talking about here. Okay, unfortunately, hospitals are on that list of potential targets. Give you some ideas of some others: the water supply, power grids, oil supply and aviation, food and basic necessity supplies, banks, transportation infrastructures. You know, not too long ago, in early 2021, actually, we had a Florida water treatment facility in Oldsmar, Florida, that was attacked by killware. There, they breached the water treatment facility systems and boosted the level of sodium hydroxide into the water, and it far exceeded the safe limits. In fact, it was considered a lethal dose, more than 100 times the safe limit. Luckily, somebody, an operator there, picked it up, recognized it, responded quickly, but for a few minutes there, that water supply was at risk of being delivered to thousands of people, a contaminated, lethal water supply. Okay. Now, that doesn't keep you up at night. I don't know what will. When you talk about medical devices, you talk about heart monitors and, you know, devices that will keep people alive at home. What can I say? Patch, patch, patch. Okay. You need to patch your systems as often as possible, update them, schedule patches for the devices. Like you would for workstations or servers. These devices are just as critical, if not more so. If your device provider is not adequately patching your devices, then you've really got two choices. One, switch to another vendor. And if that's not possible, make sure that the device is disconnected from the network if possible, or at the very least, ensure strict access controls and safeguards. You know, in terms of liability, think about this as sort of a products liability type scenario, where everybody is going to be liable, potentially liable, and everybody's going to be brought into a single lawsuit. So you've got the device manufacturer, you've got a facilities, you know, let's call it a plant, potentially a plant design company, plant construction companies, engineers, architects, health. If we're talking about healthcare, we're talking about healthcare organizations where a patient was treated. You're talking about physicians who may have implanted a device. Anybody who is involved in the supply chain is potentially liable for something like this. And I can tell you through experience that, you know, plaintiffs' lawyers will be looking to bring these kinds of cases because it can be very lucrative for them. And you just have, you know, we're going to have to defend them. It's going to be a whole area of litigation. You know, for a while there, environmental litigation was big. After environmental litigation was securities litigation. You know, we're going to go through a whole series of cyber litigation like this. And, you know, all I can say is your first line of defense is in your system security. So Tom and Roger, you're the first line of defense, and everything kind of flows from there. And I got to tell you, if you have a good system and you're able to show that it's robust and people are paying attention to it, and you're doing what you can in good faith to keep it updated and keep it alive and keep it well maintained, that's going to go a long way in any defense. You know, especially if there's intent, an element of intent that has to be proven. You know, how can you show that an entity intended, say for an intentional tort or something like that, intended to have harm, you know, have harm be caused or neglected to, you know, protect against harm if you've got all these systems in place? It's going to be hard for a plaintiff to overcome that. So, yeah, it's a really scary. Killware is a very scary topic that needs to be addressed, and you got to stay vigilant.
Great, thank you for that. You know, great point. You know, and as for our audience, either if you have any questions, please put them through. I think some of them may be having nightmares tonight. You know, I'm going to go, Roger. Hearing all of this, what do you foresee as the future for internal audit and compliance as it relates to cybersecurity? Like, for example, do you see the role changing in the future? And if so, why?
Yeah, great question. I think that I'm fortunate to be in a progressive organization where we've already started some of those activities, and it's been many years since this has been going on, and the previous vice president of our area picked up on it early and became a knowledge expert on penetration testing, which is kind of an internal audit project. And then the outcomes of that penetration testing led internal audit, because of the HIPAA privacy, HIPAA security connection, into a strong relationship with our audit committee of our board of directors. And so we're fortunate that we already have that relationship with the governing body. They see us as partners and knowledge leaders in that area. And so when we ask to test things, when we ask to get funding for pen testing and their approvals related to that, when we've, you know, we're pretty deep into high trust, you know, those types of activities in other organizations, they may have difficulties getting that ball rolling. In our audit committee, one of the standing topics is cybersecurity, and our CISO attends and is very well respected, and I think that's great. What's our other role? Test. And you know, we enjoy that. The people that we do test probably don't enjoy it as much, but it also gives us an opportunity to go out and interface with our internal customers as well as our external customers. I think a big piece that I've gotten involved in the past 2 years has really been working with legal and the business associate agreement, third-party risk assessments, and really driving home with our CISO. So we're really fortunate, again, to have strong performers with our CISO, compliance, and legal, as well as senior leadership, to be able to push that forward. So when our CISO said we're going to have minimum security requirements based on NIST 20 and other frameworks on every contract that exchanges, well, everything, but especially PHI, because that's the crown jewels, we didn't get much pushback, and that's great. So then, of course, the stuff comes to my desk for auditing to see if it's appropriate, and I think that that's going to be a big activity in the next 2 years, verifying those third parties, what they told you, is it true, and working through that. I hope that answers the question. I'm also really lucky that I have an internal system security auditor that actually works within the internal audit compliance department. And so he sees stuff on the ground level as he's testing for role reviews and you know, those types of Active Directory controls and those types of things. So he's able to kind of bring that stuff forward to me, and then we can build it into our work plan and our risk assessments going forward. It also gives us a leg up on the internal customers. They trust him, so they trust the audit process, and that's a big deal.
Okay, excellent.
Hey,
Thank
Matt,
you.
just
Yes.
real quickly, Roger raises a really good point about indemnification. You know, covered entities in their business associates agreements should have a strong indemnification provision in there where the business associate indemnifies the covered entity against any claims or losses associated with the business associate's unauthorized disclosure of PHI. So that's a really good point, Roger.
Thank you. And Tom, how do you view cybersecurity from your role as a VP for Systems Integration and Technology, and how do you feel it should be viewed from the lens of the C-suite executives and board members? In the past, Yahoo has suffered really catastrophic, really bad data breaches, costing them a significant amount of revenue. And I think what we found is that it wasn't led from the top down. So could you elaborate a little bit on that? And also, what advice would you give the audience who are in your position and or in a CIO or CTO role in relation to cybersecurity responsibilities? And what should be expected from a CIO, CISO, CTO in terms of cybersecurity accountability, which I think is very critical to have a level of accountability as well.
Great question. We absolutely, leaders in the information systems world, the information technology world, we were the security people before cybersecurity became, popular. It was upon us to make sure our systems were functioning, always available, and doing all the right things from a setup and setting up the parameters and everything else to make sure that that system's up and operational. Add to that now the fact that we have to make sure that we're doing all the right security rules and setting that up, making sure our staffs are educated on security. It is not just the CISO or the information security officer's job. It is their job for the program and to make sure you have a comprehensive program and that people are following it. But it is upon everybody to execute on that. Everyone in the organization, every employee needs to be educated and take accountability for their actions and take safeguards, do the right thing with data, with their equipment, everything. So, the CIO's role is just as important. I mean, I think all CIOs take on security, even though it may be not their primary responsibility, because they're wearing many hats, they're doing lots of different things. They're not focused just on security, but they absolutely have to take accountability to make sure every system that comes in gets implemented appropriately in a secure fashion. Their staff, like I said, educated and trained on security and make sure that they're all following the policies and the rules to keep that information safe and those systems up and operational. So it is everyone's accountability. And I can tell you from the Inspira board, they take it extremely seriously. They want to make sure they're very active and want to make sure that they're doing whatever to support the security program and make sure that we're doing what we need to be doing in order to safeguard our patients.
Okay, excellent. In the interest of time, I'm going to move into hopefully to some of the more juicy stuff, but counsel, without disclosing any confidential information, what was one of your most memorable data breaches which you could share with the audience and lessons learned? Also, what advice can you give the audience in selecting not only a good law firm, but in ensuring that they have the best lawyers possible to ensure their interests are appropriately represented in relation to cybersecurity impacts on healthcare providers?
Well, Matt, I thank you for the softball. I appreciate it. Let me take the lawyer thing first. It's really important to have a cooperative relationship with your lawyer if you're an organization, especially a covered entity. That doesn't necessarily mean me. There are lots of good outside law firms that work with folks on this call every day. And the organizations around the state, and especially the larger ones, have really great in-house counsel departments. you need to bring them into the equation early enough, because you never know what you're going to find too, and you never know what the discussions are going to be like. And if you have your lawyer involved, you have the best, you position the investigation the best way you can in order to keep information as confidential as you possibly can. The one thing that we bring to the table that no one else really brings is the attorney-client privilege. And that's something. It really is, because, and it's not absolute in all respects. But if you're having communications internally and a lawyer is not involved, those communications are not going to be privileged or confidential. So I think it's important to keep that in mind when you do an investigation. You know, I had a client a few years ago who was hacked. Ransomware was installed on the system on a Friday, a late Friday afternoon. Of course, they always happen on Fridays. And it brought down the entire system. And it was a multi-facility, multi-physician, multi-practice, cancer, rad-onc type of organization. Got the call, and the first thing we did was we brought in a SWAT team, you know, the forensic SWAT team. They got to go in, and they have to see. They got to get the who, what, when, where, and how, and why of what happened. You know, who went in? How'd they get in? Was it front door? Was it a back door situation? Was it through users at you know, like employees, or did they encrypt code and get in? How long were they in? What did they do when they were there? Did they access protected health information or not? Were they just clowning around? Were they just kind of searching? We notified the FBI. We found out that the hacker did not access PHI. It was amazing to me that we were able to determine that and determine it so quickly, because you got to remember, not every disclosure is an unauthorized breach, and not every disclosure has to be reported. And if you get down to the facts as quickly as you can, and that you're in a position to take action to fix it, to minimize the effects of what's been going on, to get, you know, the bad actor out or away, and, you know, to take additional precautions and maybe even discipline employees, then you're gonna be better off. But in that case, the hackers, it was long enough ago now, they only asked for $30,000, which we had to pay in Bitcoin. So converting, you know, cash to Bitcoin is another, you know, cryptocurrency is a whole nother activity that you have to do. And we found out that the hackers were from North Korea. So, you know, you have to be aware that these folks are going to be swinging away very often. Well, we got the system back and up and running on Monday because we paid the Bitcoin, and the encryption code actually worked, and they got the system back. So they were back up and running. You know, there used to be a day in a kinder, gentler cyber attack world where the attackers were really only after money. So they wouldn't price the ransom too high to make people not pay it. And so they priced it right, the right amount, so that they would get the money. Now, the federal government is now is discouraging payment of ransomware now. This is, you know, 4 or 5 years ago. And they are issuing new rules, and there's a new advisory that's out. Let me just get it for a second. So there's an advisory that was just issued on September 21st from the Department of Treasury, which says that all U.S. entities and individuals are prohibited from making or facilitating ransom payment to an individual or entity on the Office of Foreign Assets Control, OFAC, specifically designated nationals and blocked persons list, or other persons or individuals, entities, or governments blocked by OFAC or covered under United States embargoes. So you're talking about Iran, North Korea, Syria, and the government is saying, and I don't know how this is going to be enforced. This is going to be really interesting to see how, but they're saying, look, we're going to penalize you if you just pay this ransomware, pay the ransom rather, as a result of being attacked. If you're paying it to an entity that falls on this list. So again, Tom and Roger are your key people. If you know that there's a hack, you go to them first because they're going to know what to do. And it's important to engage them quickly. You know, that's my best advice to everyone on the call. But it's going to be an issue, and you got to be vigilant. I mean, that's the takeaway from this conversation, I think.
Great, thank you. And then we have, it's 3:20 now, but we have a couple of questions that we can answer quickly before concluding the symposium. With telehealth increasingly used now, how do you see the coming challenge as a result of telehealth in addition to current cybersecurity risks?
Interesting thing about telehealth is that a lot of times it's just a video stream. There's not a whole lot of data passing back and forth. Usually the EMR is not connected to that telehealth visit. It's done separately by the physician. So I think there's minimal risk, you know, a recording of what was going on, so some PHI possibly, but I don't see that as a major cybersecurity issue for us compared to many other things, especially the medical devices.
Yeah, I would put that a little bit lower on the list, Tom. I think you're right. You know, the medical device list, they're up there, number one, I think, medical devices.
I'm actually worried about the telehealth a little bit more from False Claims Act stuff than I am from cybersecurity. So, yeah, it's just, you know, volume and things like that. But yeah, and I agree, you know, using secure platforms, making sure that there's proof of securities, those types of things, they're pretty easy. If I can understand them, then they must be pretty easy to understand how that chain works.
And then our last question, this one for Jim. What about the catch-22 of paying ransomware? If you are a victim of ransomware and systems are locked, HHS and OCR demands that you get the data to determine if they were breached, which is presumed. But if you pay, the Department of Treasury will penalize you for paying the ransom.
Well, you got to remember, the Department of Treasury is saying that if you pay ransom to an entity or individual that's on their list, so that's the real risk there, okay? It's not just paying ransom to anywhere. Some kid, 15-year-old kid in their basement hacks your system and wants a life supply of bazooka bubble gum. That's not gonna raise the Department of Treasury's eyes. So, you know, again, I think, and I can't stress this enough, but if you're in that situation, and I don't want to be the bearer of bad news, but I mean, eventually you might be. I mean, it's not a question of if, it's when. You're going to have to deal with something like this. When you're in that situation, the worst thing you can do is hide it. Don't be an ostrich. Don't stick your head in the sand. Go to your privacy officer, tell them what's going on, or her, and you know, let them work it through with you. But, you know, they don't know what they don't know, the privacy officers. You gotta be upfront with them.
Great, thank you so much.
Yeah, at this time, we're gonna wrap this up. Really, really great discussion, everybody, on cybersecurity. On behalf of Withum and Matt, certainly, want to thank the panelists here this afternoon, certainly Tom, Jim, and Roger. Really just, it kind of, keeps you, what keeps you up at night, and this is certainly a hot topic, not only in healthcare, but in all industries. And Jim, the points that you made that, Roger and Tom are, quote, the first line of defense. And, it's not just a matter of if, it's when. And certainly applaud your efforts, guys, and everything you do to keep our patients, families, friends, PHI data safe, but also them safe with kind of that killer outcome, if you would, or the killer act, which is really a scary thing today. So again, thank you very much. If everybody can just hang in here, we're going to wrap up in a couple of minutes. Just Rachel and I and Anna, we're going to wrap this up. Haley and Mike, thank you as well for your great efforts from Withum. I want to thank the audience for joining us here again this year for the symposium. Those of us on the Northeast, we were worried about weather, and we said, geez, good idea to keep it virtual, notwithstanding the ongoing pandemic. So that's a good thing. I want to thank Dr. Klasko for joining us today as our keynote, and I want to thank all the moderators and all the panelists in all 3 sessions. I learned a lot. I was intrigued. I was interested. It was really terrific. So just a shout out and thank you to all those individuals for joining us and spending their day with us. And lastly, I need to thank the MVP of this thing, Rachel Gisser, who really pulled this off together. She did a great job again this year. And on behalf of everybody, our MVP, Rachel Gisser, in charge of marketing for our healthcare team, does a great job. And with those accolades, I'm passing it to my right to Rachel, who's going to wrap up the program today. Thank you very much for joining.
Great, thank you so much. And thank you everyone for joining. Please remember to complete the survey after this webinar to qualify for credit. Certificates will be distributed in a few weeks, and you will receive your CPE certificate from Withum and CLE certificates from NJHA. Please be on the lookout for our upcoming CPE webinars and save the date for our symposium next year on Wednesday, December 7th, 2022. On behalf of everyone at Withum, we wish you and your families a safe and happy holiday season and a terrific new year. Thanks again so much.